Good morning, everybody, and welcome to the Virtual Concussion Symposium 2020. It's been quite a year, and I want to thank everybody for joining us this morning. I want to give a quick thank you to our sponsors, TMC and Spark, for putting this thing together. And we are here at the core today, Health and Wellness Center of TMC, and also a big thank you to them for helping make this event come to life in a virtual format. And usually I love seeing all of you guys here. Instead I'm looking at cameras today, but it's still really a privilege to be able to continue to do this. This is our second inaugural year doing this, and it was obviously jeopardized with COVID, but we had the opportunity to do this virtually and have actually had the chance to be able to get a number of other folks into this conference. Our turnout has been significantly higher than even last year, so we're very excited about that. So I do want to give a big thanks also to Rick Anderson, CMO at TMC, for having the impetus of getting the Concussion Symposium going last year, as well as Jessica Mitchell, who's here with us today, for everything she's done year after year, being the catalyst of putting this thing together, and of course all of our wonderful speakers that come out every year to speak. So I'm going to move into our goals for today. So briefly, I'm going to cover an introduction and some 2020 updates. We'll talk about return to learn, return to sport, cervicogenic symptoms, migraine, mood and sleep, and low curveball at the end with the COVID guidelines. There's been high demand for that, particularly in the sports med community for return to sport and return to play, which we're up against that as we speak. And then a multidisciplinary panel, expert panel at the end, which will include some of our great therapists in the community who will be talking about a case that I will be reviewing. So some housekeeping items. I did want to, for CME, I did want to review the accreditation. I'm supposed to read this, so I'm going to read this to you guys for your CEUs and CME. THMEP is accredited by the Arizona Medical Association, ARMA, to provide continuing medical education for physicians. This activity has been planned and implemented in accordance with the accreditation requirements and policies of ARMA. THMEP designates the live activity for a maximum of 4.25 credits. Physicians should claim only the credit with the extent of their participation with the activity. We will have some breaks today. We'll have a few of our sessions and then have a break. And the breaks will be about 15 minutes. If we run over, the breaks may need to be shortened just for the sake of staying on time. We will have all of our slides and handouts and references that we point to on our website, so feel free to hop on there, sparktucson.com. We will also have them on the TMC website as well. We will try to address as many questions as we can. There are already a lot of questions coming in, so we may need to save some for the end and also answer some of those questions on the website as well. So if you don't get your question answered, you can look for it there. Finally, financial disclosures. I'm going to get into my talk. Each provider will talk about their disclosures or lack thereof. So again, I'm going to be covering a quick intro and best practices and evidence-based updates in 2020. So my objective specifically for this first 30-minute session will be a case review. I'll go over the consensus summaries, evidence-based updates, and talk about concussion subtyping or concussion phenotypes, which is a relatively new concept, but I believe the way of the future with respect to how we deal with concussions, and talk about some updated targeted management within those subtypes or phenotypes. So I'm going to get started with this first case, and this case is a sort of general case that sums up a lot of the type of more complex head injuries that we see in our clinic. This is a 13-year-old boy who was elbowed in the head playing basketball. No loss of consciousness, did have some headache and dizziness. He's assessed on the field by his coach, didn't have any red flags. continues with regular school activities the next day, but does complain of ongoing worsening headache and new migraines. At 4 weeks out, he's still symptomatic, so he sees a neurologist and is started on a medication, Topamax, for his headaches. There's an MRI obtained, which is normal. The symptoms continue to progress. He's no longer tolerating sports at all because of exercise intolerance, so not even able to go out and just work out. Struggling with his academics, really starting to see dropping grades, starting to feel depressed, and is expressing some level of hopelessness in his appointments as well. And up to this point, he has had no academic accommodations to support him through the morbidity he's going through with his concussion. So we finally see him at about 3 months. At this point, he has severe ongoing cognitive deficits, vestibular-ocular deficits, exercise intolerance still, and a lot of cervicogenic pain and dysfunction along with migraines. So the question is, what now? And I know many of you have probably seen these cases or heard of these cases. And to answer that question, that's what this whole morning is all about. So all our different speakers are going to dive into specifics with some of the deficits that this young man is having. And the expert panel will also dive into those specifics. And we will show you how this is not an easy question to answer. The answer is really within a multidisciplinary approach involving a lot of different therapists and a village approach with respect to care and the optimal healing environment that's created for this young man. And to really start to answer that question, what now, we've got to go back and debunk some of the outdated myths that are still out there, floating out there, and move toward this modern evidence-based paradigm that we now have for concussion management, right? So, and you guys have all heard this. It's just a concussion, you'll be better in a few days. If there was no loss of consciousness, I mean, this kid didn't get knocked out, so there really shouldn't be a big concern. The MRI is normal, which means you're good. Concussions don't last more than a couple of weeks. It's just your migraines, you're just depressed. So these are all tying into themes that we're going to cover today, which is, concussions don't have persistent symptoms, that there's an arbitrary timeline, a couple of weeks, and everyone gets better, and that's not true. That if you have any comorbidity, say you already have some anxiety or migraine, that if you have symptoms that are much, much worse after a concussion, that just must be you. But the reality is we know that concussions really have a huge impact on comorbidities and worsening them, at least temporarily. So quickly, I'll whiz through a couple of slides on background, and then we'll sort of get into the updated evidence. So basically, there's a lot of concussions. We know that 2 to 4 million concussions a year. I think the key point on this slide is I want everyone to remember this, that if we look at up-to-date evidence, it's only about 10 to 25% that ever have loss of consciousness in the mix of their signs and symptoms. So if you're using that in any way to determine if someone has a concussion or not, that is greatly outdated, and we want to move along from that. So what is the definition? So there's still no universal definition. I'm hoping in the next couple of years there will be a consensus on this, but bottom line, the definition we've been working with for the last 5 to 10 years is a functional impairment that's temporary. Now, some of the data is showing that there is probably some microstructural damage that occurs at the level of the white matter, which I'll get into a little bit today. But essentially, that's why we see normal CTs and MRIs, conventional CTs and MRIs, because the real abnormality with concussion is functional, and you really need to dive into functional testing to see it. So how does it work? So you do have to have trauma to the brain, so you can't get a concussion from your annoying brother or something like that. The trauma has to be there, and it does not need to be directly to the head. It can be translated forces from the body to the head, but ultimately those forces result in an impairment in the normal brain function because the neural metabolic cascade and the electrolytes and chemicals of the brain have been altered, and that disturbs the normal pathways of the neurons and ultimately manifests with increasing daily symptoms and with school and other activities like that. This is the neurometabolic cascade, and this is a relatively sort of simplified cartoon, but essentially when you have trauma to the brain, You do have a depolarization that occurs at the level of the axon, which then propagates down. You have a rush of potassium out of the cell, a rush of calcium into the cell. The calcium is toxic to the cell, shuts down the mitochondria, and you have an energy crisis in the cell. And that's ultimately what's going to be the underlying neurometabolic cascade of the primary brain dysfunction that we see. So what about the timeline? So yes, in general, we are looking at a couple of weeks, and thank goodness for that. However, the big point on this slide is about 30%, and we've seen this number slowly inch up every few years as we look at it. In the past, when I've done presentations, it's been 10 to 20%, but if we look at the last couple of years of data, it's really closer to 30%, particularly in the teen group, that have prolonged symptoms or persistent post-concussive symptoms. And so really once you get to about 4 weeks, that's where we are defining prolonged symptoms. So that becomes a critical time if your patients are not better or almost better to go ahead and get them out for concussion services at that point. So how do these concussions present? I think the key point here is there is multiple manifestations of the presentation. There is no classic presentation that you can stick to, headache, dizziness, whatever, however you want to think about it, that will suffice for every case. The reality is they're all unique and they need to be treated that way. Their symptoms are generally going to fall into physical, cognitive, mood, and behavioral, those three categories. But of course, within those categories, there's many questions to ask. For example, with physical symptoms, are we talking about headache, dizziness, nausea? Are we talking about vision disturbance like blurry vision? So those are all the details we need to dive into. The SCAT5 is a great tool for those of you guys that are just asking questions and don't have a great intake form for concussion. I think it's essential that you have that. There's 23 questions here that are focused on those three categories, and it's much easier to have this handed to the patient and have them sort of fill that in as opposed to you trying to sit there and ask all those questions. And if all you're asking about is do you have a headache and did you have loss of consciousness, it's not nearly enough. We need to dive into, again, all the physical questions, but also the cognitive domain and the mood and behavioral domain as well, which includes sleep. So we talk about red flags, and this is directly off of the SCAT5 and also originating from the PCARN data from our emergency room studies that have been done in over multi-site studies. And I think the big thing here to keep in mind is any focal neurologic deficits, prolonged loss of consciousness. So if more than 30 to 60 seconds, certainly longer than a minute, that's something to think about, and that's someone that may need a CT. Certainly deterioration of symptoms, worst headache of their life, really severe 10 out of 10 headache. Altered mental status, obviously seizure activity, and any suspicion for a skull fracture. Those are all red flags that would need to sort of get your patient out to the emergency room or wherever they can potentially get a CT scan, and also elevated level of care if they do have a bleed or something like that. So here's a number of recent consensus statements. These are all in the last few years. CDC, AMSSM, the Fifth Consensus, and AAP, all consensus statements on concussion management. And here's the summaries, okay? Number one, we want to avoid routine CTs and neuroimaging. Why? Because this is not generally a structural problem. This is a functional problem. So the testing needs to be focused on a multidisciplinary functional testing regimen, right? So in most ERs, that's going to be what you're doing with the exam, the vestibular motor screen, and then once they get into our clinics, it's usually going to be cognitive testing, exertional testing, so on and so forth. Validated tools are important to use here. The SCAT5 has been around for a few years now. Impact and other cognitive tests are well-validated tests that have been around for a couple of decades now. And the vestibular motor screen is a validated screen out of UPMC in 2014, which has been a big-time game changer in concussion management. So those are things to be familiar with for those of you guys that are basically managing concussions. The other key point from the consensus summaries is that 20 to 30% of these folks are going to have prolonged symptoms beyond 4 weeks. And that's, again, the general definition we're going with. So at that point, or certainly in that 4 to 6 week time frame, you need to be thinking about, is this someone that needs to get referred out for more comprehensive care? And there are some risk factors that we'll get into today that can help you identify someone early on that may be a high-risk person for having prolonged symptoms. Okay, that has to do with their predisposition, if they, let's say, already had migraine history or whatever, but also with their presenting symptoms. That can give you some sense of whether they're going to be prolonged or not. And a couple of other critical points. So avoiding absolute rest for more than a couple of days. Of course, this is all case by case, but in general, we want to get concussions getting a relative dose of cognitive and exertion in a rehabilitative way early on. So the idea there is don't keep them out of school for 2 weeks. Focus on a customized return to learn plan that can give them the modifications that they need so that they can get back into that environment but not be overloaded. And so, our next speakers will be diving into that, for example. Active rehab. So what is this? An exertional rehab program that allows them, same concept, not to just be completely shut down from exercise, which we know is critical for brain and brain recovery and brain function, but to give them the appropriate dose at the right time. And usually there's some testing that's necessary to figure that out. And ultimately, that rehab is the sort of critical management for concussions, okay? It's not just rest, it's a combination of rest and rehabilitative measures that include exertional rehab, so the early exercise, vestibular ocular and cervical rehab when they have those issues. And really medications should not be necessary. There's no FDA labeled approved meds for concussion. So really rehab is the way we go. There are situations where we need to utilize some meds, but those are going to be far and few between. So this is kind of the summary of it all, which is that return to learn and cognitive support are very important. We want this multidisciplinary therapeutic approach that also includes a return to play protocol and exertional rehab, vestibular rehab, cervical rehab. And again, no FDA-approved medications for concussion. So if the first thing we're thinking about is how can I treat your headache or your dizziness or your nausea with this medicine, that medicine, then that's not the right approach. We need to be thinking about trigger avoidance and rehabilitative measures. Okay, so let's talk about some modern evidence-based concepts. So we talked about prolonged symptoms, and I think it's important to dive into the recent papers that have really supported the fact that when you have someone 3 months, 6 months, 1 year out with objective signs of ongoing problems, that they have ongoing problems. It's not in their head. And also looking at when we see people in that prolonged stage, well, how many of them, they're not all created equal, so how many of them are at 3 months, 6 months, 9 months, 12 months? We had a nice study we did on that, which I'll share with you. And then also, what, again, like I alluded to earlier, what are the predictors that may help us identify people that are high risk to fall into that category, and are there things we can do to help prevent that? And the main things are going to be early intervention. So in general, early intervention, regardless of who you're talking about, all comers, early intervention leads to better outcomes. And that means quicker time to recovery and lower symptom burden. So early intervention is key, and there's been a plethora of studies, even in the last 1 or 2 years, that have really highlighted that, and I'll pull some of those up for you. And then finally, evidence for ongoing brain injury. So if we do have a situation where someone is having ongoing persistent symptoms beyond a month or 2 months or 6 months, what kind of evidence do we have to be able to sort of tease out that that is primary brain dysfunction and ongoing post-concussive as opposed to just their anxiety that they had that's now heightened or whatever it might be. And some of the new research is also allowing us to dive into microstructure, and DTI is the big one, so that we can actually look at micro damage as opposed to macro damage, which we know with CTs and MRIs is usually not part of the concussion picture. Here's a few studies looking at persistent symptoms. So I really like the TRACK study. You guys should check this out. All these studies will be on our website, so and the slides will be available. So you'll have the references to all these. I'm not going to dive into them in depth. But the TRACK study is a very good one because what they do is they followed patients at 2 weeks, 3 months, 6 months, 12 months, and look to see what kind of ongoing post-concussive symptoms they had and functional impairment and effects to life. So, and what they found is at 12 months, there was still a significant number that had these functional impairments and post-concussive symptoms. So a really good recent study that is looking at the reality of persistent symptoms in post-concussive patients. The one on the bottom left from Iverson is a good recent study, I think in 2020, and he's looking at high school athletes with a history of ADHD or learning difficulties. So those that have these things, when he dives into their history of concussion, finding that there's a greater lifetime concussion history in those that are having these learning disorders. So there's some effect that is persisting potentially with these folks with respect to cognitive. And certainly we're seeing that more in folks that have multiple concussions or even one concussion as opposed to those that have none. And on the bottom right here is another interesting study looking at complicated versus uncomplicated concussions. And that's defined as whether there are CT findings or not. And basically, at 3 and 6 months, they're looking at ongoing symptoms. And even at 6 months, both 3 and 6 months, but even at 6 months, the level of symptoms that these two patients are having are not very different. So again, support that you don't have to have CT findings or big bad findings on imaging to be suggestive that you can have persistent symptoms, even at 3 and 6 months. Here's a study we did out of our facility, a small pilot study looking at 153 patients with persistent post-concussive symptoms or symptoms greater than 4 weeks. And this is kind of how they mapped out in terms of how we staged them. So stage 1 would be still under 3 months. Stage 2 is 3 to 6 months. Stage 3 would be 6 to 12 months. And stage 4 is basically more than a year. And stage 4P would be more than 3 years with some permanence. So what you can see is most of these folks with persistent symptoms are falling within stage 1, 2, and 3. And it's a relatively shared pie, you know, so most of them still got better in 3 months, but you can see a pretty good percentage was 3 to 6 months and 6 to 12 months. But luckily, we didn't see a huge percentage that went beyond a year, but, you know, about 10%, which is still significant. Oh, and the other thing I want to point out on the bottom there, the two that have the two types of phenotypes that had the most prolonged symptoms were migraine and cognitive. So we thought that was an interesting finding, so that there may be, if you're starting to see that folks fall into those types of subtypes where their predominant symptoms are migraine or cognitive, that they may be more likely to have prolonged symptoms. So what about the predictors of morbidity, predictors of prolonged symptoms? We talked about this a little bit. So these are the early risk factors you can look for to try to jump on these patients a little bit earlier with respect to comprehensive care. So severity of initial symptoms. Someone comes in with a really high symptom burden, certainly someone who's coming in with migraine type headaches as opposed to just headaches. So those migraine type headaches are going to be dizziness, nausea, photosensitivity, sound sensitivity. Dizziness alone has been shown in a number of studies to be a risk factor for prolonged symptoms. The suggestion there is dizziness correlates with the vestibular ocular motor screen being abnormal. And when you have an abnormal vestibular ocular motor screen, we've certainly seen that those folks take longer to recover. Not just mildly abnormal, but if it's significantly abnormal, that's definitely been a predictor for us for prolonged symptoms. Sleep and psychiatric comorbidities, delayed care, we'll get into that a little bit. And then severe visual deficits. So in particular, those patients whose near point convergence is, you know, outwards of 20, 30 centimeters, having a really hard time with vision and balance, those folks generally going to take longer as well. So let's talk about early intervention and the importance of early intervention. So what are we talking about when we say that? It covers a few different points. Removal from play is where it all starts, right? I get a concussion, I feel concussed on the field, do I keep playing? Or am I in an environment where I get removed and assessed and held out? Immediate care afterwards is very important. Concussion care with some of the details like the SCAT5, the VOMs, the cognitive, and then early rehab and decreased morbidity and time to recovery are all important as well. And I think the key is if we can get early intervention, we have decreased symptom burden, faster recovery times, and lower incidence of prolonged symptoms. Here's a number of studies that have looked at this. And you know, again, I'm not going to dive into these, but the bottom line here is the first study in the upper left showing that if folks are seen within 7 days, they have better outcome and lower symptom burden. The one on the bottom left from David Howe, these guys are showing those that have been removed from play end up doing a lot better than those that continue to play. The pediatrics journal there was one out of UPMC in 2016, showing about a 9 times higher likelihood of a prolonged recovery in those folks that continued to play. And on the upper right is early treatment or early evaluation, even in the emergency room. If it's within 12 hours as opposed to after the first day with some of these significant injuries, it makes a difference with respect to symptoms at 1, 4, and 12 weeks. So what about evidence for persistent injury? I think the important thing here is looking at these functional impairments. And we have a number of different tests, cognitive testing, vestibular-ocular testing, even some good studies coming out looking at evoked potentials in neurophysiology. So these are all going to help us in one of the new areas as well as microstructural injury on DTI to really provide objective evidence for persistent injury that matches up. So here's a number of different examples that we'll get into a little bit more down the road today of some of these objective tests that can be done. This is an example of DTI. On the left, you see an example of the mohawk pattern of these distal fiber tracts emerging from the corpus callosum that have been basically, looks like they're balding because you have truncated fiber tracts, you have a loss of integrity of these fiber tracts, and this is how you're looking at that micro damage. Co-morbidity, I think this is important. There's often overlap. Okay, comorbidities, a lot of us have that, and they make it sometimes difficult to tease out, is it the comorbidity or is it the persistent symptoms? But bottom line is it's important to remember that if people have baseline weaknesses, whether it's vision or motion sickness or whatever, they're going to be more prone to those systems being even weaker after the concussion. So compared to baseline symptoms, don't just say you already had migraines. Are these migraines the same frequency and severity as the migraines you had before the concussion? If they're not, the concussion is probably playing a role in making those worse. And again, objective testing can help us to determine is this persistent versus baseline comorbidity. So these are targeted treatments for phenotypes, a number of different studies looking at concussion phenotypes. And this one in particular I wanted to point out came out, it's a fresh, hot off the press, May of 2020. This is called the CP screen, the concussion profile screen out of UPMC, a great screen that can be utilized to break down our subtype domains for us. I'll have access to this paper for all you guys on our website as well. And it is high validity reliability, concurrent high validity with other screens that are out there, but also the VOMs and the impact. And I think, again, a great screen that can help us with concussion phenotyping moving forward. So if we look at subtypes, basically a number of different studies have looked at this, and the breakdown in terms of the summary of these is basically this. So migraine and mood tend to be the most common. If you combine vestibular-ocular, that tends to be second. Vestibular specifically seems to be a higher profile in kids, but there is good inter-rated reliability agreement across these profiles, although we're not as good as ranking what's number 1 and 2, but we do recognize them pretty well. Here's a schematic which just shows how do we define these phenotypes, starting with the symptom profile to see which symptoms match with the highest level of profile they have, but you can take into consideration other things like exam findings and their predispositions. And then targeted management, I think, we have a couple of different versions of this, but the bottom line is we have a lot of new targeted managements here, and exercise is going to be one key thing that's throughout all of them, and that's the active rehab protocol. But otherwise, if you're dealing with someone who has, for example, a primary vestibular problem, and that's their primary profile, well, vestibular rehab's a big deal for them, and maybe if migraine's second, then you would go down the specific targeted management for migraine. Here's an updated version of that same schematic, which includes sleep and exercise intolerance with a number of the studies that are in the last few years. So what about some of the things that we're going to be talking about today as the other speakers come up? So updated targeted management. Dr. Tees will talk about migraine, CGRP3 agonists and certain biomarkers that can be used. This is a situation where as we start to look at biomarkers, which have been in the game for a while, we may be able to use those biomarkers to determine if someone's more of a migraine subtype or phenotype, and then more likely to treat them with migraine medications. So that's another very important piece to that. Folks today will talk about active rehab protocol, vision, cognitive, mood and sleep, as well as cervical. So you'll get some of these updated targeted management approaches today. So our references, and you'll get more of these today, but some of these specific references can be found on our website that I alluded to today. I know I went through a lot of studies quickly, but you can access them all, including the CP tool, the concussion profile tool, which I think is going to be a big one. I do think concussion phenotyping, again, is going to be the way of the future, so getting ready for that. Thank you for your time. Do we have some questions here? Okay, good. So we've got a question up on the screen. Do you recommend the use of VOMS as a sideline tool or a in-the-clinic tool or both? I would say, so absolutely I recommend the VOMS. Validated screen out of UPMC 2014. Look at the paper. There's some great videos on the VOMS if you're not sure how to do it. And we use it in the clinic every time with every visit in concussion patients, and I think it is absolutely useful on the sidelines as well. So the answer is yes and both. Next question, what sort of discharge instructions would we provide from the ED in a patient with concussion? So I understand in the emergency room it's hard to dive into sort of comprehensive care and all the details. So I think the most important thing is if you've got someone that's going back to school or work, and the next presenter is going to talk about that, to have some sort of return to learn or return to work program in place, and it might mean they need a day or two off. It shouldn't be more than that. It all depends on the individual case, but having some sort of written documentation that lets people know they have a concussion and they may not be able to handle full workload, whether it's school or work. And then also something that pulls them out of sport. And then I think the third thing that's very important is follow-up care. It is really important, even if the CT looks good and they overall look pretty good with some minimal symptoms, that they follow up at least with their primary so that they can close the loop to a concussion being better. If it's truly a concussion, they're not going to be better walking out of the ER. We know that. So, one more? Okay. So if they do not have insurance, what sort of resources are available to help them determine when they should go and see a specialist? So I would say, if they don't have insurance, I would take advantage of some of the community resources that are out there for us. And number one, we're going to hear one of our athletic trainers speak right now, but number one in the schools is our athletic trainers. They have incredible experience and training, particularly on concussion care, and can take them through some of the tests and things like that and determine from that point what kind of care they need. The other important point is if they're student athletes, a lot of people don't know this, but the AIA provides insurance for brain injury and concussion. So they would be able to, regardless of insurance, be able to get care through their AIA insurance if they're athletes. So one more? All set? Okay. All right, thanks so much. Thank you. Okay, I am going to introduce Becky Farhado and Leslie Streeter, who will be doing our next session here, talking about returning to school and work after brain injury. Becky is one of our fearless athletic trainers that I was just talking about over at Saguaro High School. Always a privilege to have her. She has spearheaded Return to Learn for the entire district, and that was, 5 years ago when we sort of started doing that, but really an expert at that, and Leslie Streeter as well. So we're excited to have them, and I'm going to go ahead and let them get to it. Okay, thanks, Becky.
Thank you. Thank you, Dr. Mo. Thank you to Spark TMC for having us here. Today, Dr. Streeter and I are going to speak to you about returning to school and work following a concussion. So after today, we're hoping that our attendees will have a better understanding of the evolution of concussion management in the secondary school setting over the last 20 years. We're going to also discuss how the concussions affect the functional ability of the brain, and therefore the need for the schools to have accommodations for both our athletes and our non-athletes, as well as work accommodations for those people returning to the workforce. We're going to review some of the recent research and guidelines and give you the ability to individualize accommodations for returning to work or learn based on the signs and symptoms of your patients, the role of the school nurse and the athletic trainers in executing these plans, and then a new caveat this year is implementing our return to learn in our virtual world that we're in right now. So we know that there is a need. The AIA, Arizona Interscholastics Association, has dictated that schools have a return to learn plan. Now, having a plan is the easy part. Implementing that plan can prove to be difficult if you don't know some steps that you need to take. Doing the groundwork ahead of time by communicating with all the individuals necessary is probably one of the more important things that you need to do. And if you do this work ahead of time, it will make the flow of your plan a little bit easier. Not only do we need to communicate ahead of time, but we need to make sure we're following up on a regular basis with all individuals involved. And if we do these things, hopefully that will allow our plan to flow smoothly. However, we always know we have teachers who are reluctant to give their students accommodations or modifications. Concussions are very unique in that a lot of times you can't see what's going on in their brain like you can see somebody walking in on crutches. So teachers can be reluctant. But again, if we give our groundwork ahead of time and we're educating all people involved, they may be a little less reluctant to do so and therefore ensure the success of our students. So we're going to examine a couple cases here real quick. In 2008, we had a 15-year-old female soccer keeper. She was a high GPA multi-sport athlete. She was participating in a club soccer tournament. A ball was kicked directly to her face from short range. There was unknown loss of consciousness. She complained of mild headache, dizziness, and some visual problems. Somehow she talked her coach into letting her return to the game in the second half. At the conclusion of the game, she was riding home with her parents. The game was in Phoenix, and her headache increased. She complained of some visual problems and some nausea. Parents took her to the closest emergency room. They did their evaluation, gave her a CAT scan, and was just released with the instructions saying that the CAT scan is clear, and there really wasn't any further instructions that were given to our student. So, due to the signs and symptoms, she missed roughly the next 6 weeks of school. She followed up with her pediatrician several times. She did refer to some neurologists and eventually returned to school. However, when she returned, there were no formal accommodations in place. She still complained of short-term memory loss, visual problems, headaches, which obviously affected her ability in the classroom, and therefore her grades plummeted. We had no formal procedures in place. And this case, along with a couple of other in our district, spurred some of the athletic trainers to say, hey, we really need to get on ball and we need to get a plan in place. So it took us roughly 2 years to formulate our plan. And when we formulated our plan, it wasn't just for our student athletes, it was for the entire student population. So this was definitely a huge benefit for our students. So let's flash forward 10 years. So 2018, female volleyball setter. Again, bright student, 3 honors AP classes. She was in PE class. She tripped and fell and hit her head against the bleachers. With this, she saw the school nurse because it happened during the day. She then notified me because, again, we've done our communication and she understands it's a student athlete. This is what we need to do. So we gave her a student self-assessment, which I'll discuss in just a moment, and we gave her a modified SAC. She complained of a headache, some balance and visual problems, nausea, light and sound sensitivity. All in all, she reported 9 signs and symptoms for a score of 19. We notified her parents, obviously the school nurse, and her teachers. This is an example of what our student self-assessment looks like. And basically, it is just a quick check where you can have the athlete, student, fill this out, and it tracks their signs and symptoms over a period of time. And what this does, it helps us to identify what accommodations may be needed for our student to allow them to succeed in class. So we gave her this sign and symptom assessment, and we give them to them on a repetitive basis, so every day. So initially, we gave her some temporary modifications in class, notified her teachers of those. We removed her from participating in her volleyball and PE class, and we continue to have our daily follow-up. With our sign and symptom assessment, her signs and symptoms decreased over the next 8 days to only 3 signs and symptoms for a score of 10. However, on day 10, we had a bit of a setback. Before going to school, our athlete bent over to pet her dog and hit her head. The same day, we had benchmark testing at school. So she comes into the athletic training room after school, and her signs and symptoms had increased significantly from the prior days. So we questioned her about this, and she reported that, this is what happened to me today. I'm really concerned about my grades, especially after seeing how she felt she did on our benchmark testing. So we then referred her to our concussion specialist. The concussion specialist gave her a formalized plan, an ICAP. We notified her teachers of the accommodations that were needed. We removed her from her PE class, and we withheld her from standardized testing until signs and symptoms warranted the return to that. And all in all, it took her 3.5 months to return. So what have we learned from this? We know that we need to educate everybody involved. And we're educating you today by you being here. We're educating our school personnel, teachers, counselors. We're educating our parents, our coaches, and one of the more important people that we're educating is we're educating our athletes, because they need to recognize what's going on with their body and do the things necessary to take care of themselves. We also know if we're communicating, that is the key to our success. If we're not communicating with everyone involved, that's where people fall through the cracks. On the more important end of things is we know research is constantly evolving. Dr. Mo just presented some new stuff that came out this year. So we need to make sure we're staying on top of those new trends and that we have a working document and that we're modifying our document based on what we're finding in our new research. So now I'd like to turn it over to Dr. Streeter. Dr. Streeter is going to talk to us a little bit today about some brain function and then accommodations. Thank you.
Good morning. So I'm going to talk to you a little bit more about how to make accommodations, or how to make a plan for assess and make a plan for a student or an adult that after head injury that's going back to work. As you can see looking at this slide, that head injury, even a mild head injury, can affect multiple areas of the brain and cause very diverse symptoms and functional deficits that will affect their school and work performance. And Dr. Mortazavi talked about the different phenotypes, or the different domains. Sometimes there's, especially in the early part, we'll see deficits across all the different domains of cognitive, oculovestibular, autonomic dysfunction, mood, sleep, migraine, and then sometimes if they have prolonged symptoms, it will really seem to be in just a couple of areas. So it's really important to assess all these different areas so that we can be able to determine what kind of accommodations they'll need. This is just shows some of the systems that are affected, how concussions affect learning and working, and giving you an idea of the kind of accommodations they might need, or the kind of difficulties that they might have. And some of the things are pretty obvious. Like, we know if they're having difficulties with cognition, they may have difficulty concentrating and remembering. For instance, they might study for a test, or might, in work, read materials they need to read, and then the next day they really don't remember any of it. But some of the things that maybe we don't think about as much about are moods. For instance, if they're having difficulty with mood, and then it can make it very hard for them to cope with all the changes that are happening. Cope with not doing well on a test, or not being able to perform up to their regular function. Also, even small things like vestibular dysfunction can make it difficult for them to, like riding in a car can make them nauseous, riding the school bus to school can make them nauseous. Reaction time can make it so that they cannot drive, so then transportation becomes a problem. So there's a lot of things that need to be addressed. There's really no consensus for how to integrate students into the school setting following a concussion, but there's some really good guidelines or current research. The 5th consensus statement on concussion in sports talks about how to get athletes back to school, and CDC's Guidelines on diagnosis and management of mild traumatic brain injury is a really good resource. If you go online to the CDC's website at Heads Up, there's all kinds of resources for physicians, for school nurses, about how to return children. But so these are some of the guidelines that we use. There's really not a lot about the research that's been done or guidelines that's been produced about returning to work. We use kind of the principles from the 5th consensus and CDC, along with some other things and experience, to decide how to return a patient to work. So the 5th consensus recommends, as far as returning to learn, is that there be early intervention, that right after the concussion, for instance, if they're hit in a sport, that they're pulled out of the sport. They don't play the rest of the game. Absolute rest in the beginning, and then that they implement return to learn, that they have some kind of accommodations right from the beginning. It recommends that whatever we're having them do, it should not be increasing their symptoms. It should be sub-symptom threshold. And it also recommends that they get, as soon as possible, get some vestibular ocular rehab and some cervical exercise if they're having neck pain. And the studies have shown that if we do these things, we'll reduce their recovery time, we'll decrease the incident of what we used to call post-concussion syndrome, now we call prolonged post-concussive symptoms, and that we have better outcomes if we can do these things in the beginning. These are just some other things, guidelines to return to strategies, some things that gives you really 4 steps that of returning. So first, really, we want them to just get back to kind of the daily activities. That in the beginning they may not be going to school, but just getting back to doing their daily activities, getting up, doing things, and maybe doing a little bit of reading, sometimes puzzles, coloring books, even for adults, if they're really in the beginning not able to do much of anything, then things like Play-Doh, coloring are really good therapeutic activities. Then they go back to school, then start doing school activities at home or work activities at home, maybe a little bit of work from home if they're an adult, maybe setting homework home if they're a student. Then they can maybe go back to school or to work part-time depending on the symptoms, and then working towards full return back to school. And those are really the 4 levels. CDC guidelines are really more specific to just children in general, that we should restrict their physical and cognitive activity just during the first few days, and then that we gradually return them to sports and activity after 2 to 3 days of rest, not longer than 2 to 3 days of rest. There are some people that need longer than this, but generally 2 to 3 days is the most we want to give them. And that it really stresses that we need to customize the return to learn or return to school. Also, children with prolonged symptoms should be formally evaluated by a specialist. They need a more formal return to learn program and maybe some more therapy. Children with persistent vestibular ocular dysfunction, that again, they're recommending that we get some vestibular rehab as soon as possible. And also being sure they're being instructed on proper sleep hygiene. I would say nutrition as well, because lots of times after concussion, people don't eat as well as they should. They feel nauseous or don't feel good, and they don't sleep well. So they need some help with both of those things. And that I usually like 6 to 8 weeks, if they're still having cognitive dysfunction, then we may need to do some neuropsychological evaluation. And this is from the 5th consensus as well. It's recommended that when we're doing an assessment to decide what kind of deficits do we have, what kind of accommodations do we need, that we need to look obviously at mental status and cognition. We need to look at ocular motor function. We need to look at gross motor function and vestibular dysfunction. These are some of the areas. We also need to look at mood, sleep. Pushing the wrong button. There we go. Okay, so this is some of the testing. When we're assessing some of the ways we can assess, and I know Dr. Mortazavi touched on some of these, we'll just go over them very quickly. Neurocognitive testing, we use impact. If they've had an impact test, lots of times, if they're a student athlete, they've had an impact test in the schools. So then we can do impact again and compare to their baseline, and that helps us really to compare themselves before the concussion to themselves after the concussion, and that's gives us a really good indication of how they're functioning. But we can use also some other tests. Cambridge Brain Science is another one that we use that's really good. Ocular motor function can be assessed using the King-Divitt cards. Really easy, that with not a lot of, that can be done on the sidelines and not a lot of materials or a lot of training. We can look at near point convergent, we can look at tracking, we can look at how well their eyes are pairing together. We use another device called oscillating ocular motor tracking that looks a little bit more deeply at their ocular motor function. Vestibular dysfunction, we use a Bertec force plate. I know that's not available to everybody in every office, but the best testing is something that you can, and the VOMs both, you can Google, their connections to those are on our website, but you can also Google and look how to do a BEST testing or how to do a VOMs testing. Can be done with very little materials right in your office, either a training office or a pediatrician office. Then the accommodations need to be individualized, because everyone will have really different symptoms. Like Dr. Mortazavi pointed out, if you had difficulties with maybe motion sickness before, you're really more likely to have difficulties with those. If you have a history of attention deficit, then that's an area you may have a lot of deficits. And some people have deficits kind of across the board. Some people just really have a few deficits in different areas. And so the accommodations really need to be individualized. We write an individual concussion action plan, and then we send it to the school nurses, we send it to supervisors, and we send it to the athletic trainers. We send it to, have people send it to their supervisors at work if that's what they need to do to get accommodations. So first, the steps for that is first we do testing to determine their functional ability. And really, we want to decide what is their functional capabilities, because we can't really open the brain and look inside and see what's hurt like you could for a swollen ankle. So we do functional testing and what are their functional capabilities. And then we want to put them 10 to 20% below their current capacity, so that the load is not producing symptoms, so that they're able to function at that. And then as they improve, we want to keep periodically testing them and increasing what they're allowed to do, or what as their ability increase. This allows the brain to heal without causing prolonged symptoms, and it keeps the patient stimulated. It's really important that they don't just sit in a quiet, dark room with no stimulation. They need to be doing as much as they can do. Having that stimulation will actually help them their brain to heal, help them to regenerate some of those synapses that they need. And the purpose of it is to appropriately challenge without doing more than they could without accommodations. And we really don't want to go over the symptom threshold level. I kind of sometimes compare it to like a sprained ankle. If you have, I'm a runner, so if you sprain your ankle running and then you keep trying to run on it and run on it and run on it, every day it just gets worse and worse and worse. It doesn't get better. And so you really need to give it a certain amount of rest. And that's what we need to do in the very beginning, rest with the concussion. But if we put your ankle in a boot and tell you, don't walk on it for 4 to 6 weeks until it's completely better, once you take that boot off, it's going to be weak, it's going to be stiff. It really would have been better served by, after a couple weeks, just starting to walk on it as soon as you can, and then moving up to a little bit of more exercise. It's really the same principle that we use with returning an athlete to school or returning someone to work. We want to stress them just enough that they keep progressing, just enough that they keep progressing, but not overwork them so that they don't heal. So this is just really the color zones that we use. It's really we use 5 steps, so it's really kind of the 4 steps that the fifth consensus recommended. The red zone is just really the time off. Orange zone, they may be doing a little bit of school, a couple of hours. Yellow zone is half to full days. And green is they're pretty much returning to everything, maybe a few accommodations. And then blue, they're back to everything. Having the color zone really helps us be able to kind of communicate with the teachers, with other people. It just gives a broad area of where they're at. Along with the other accommodations you might make is trigger avoidance. Trigger avoidance are avoiding things that overstimulate the brain. So it's kind of obvious. Texting is a huge one. Video games, internet, TV, loud music, any known cognitive overload, just doing things that are really going to overload their brain. And with those comes a lot of incentives not to milk the system. I really have not seen very many patients that really are using it as a crutch to not do schoolwork or not do any work that they should be doing. Most people get really bored because there's no PE, there's no sports, there's no recreation, no screens, no television, no video games, adults, no driving, and they really want to get back to their regular life as soon as possible. Accommodation follow-up, Dr. Martuzavi touched on this as well, that they need follow-up every few weeks to determine where they're at so that we can progress them to a higher level. And just be sure they're moving along and being challenged but not over-challenged. They may need, if it prolongs, they may need a 504 plan if they're in school. They may need some neuropsychological testing. It's really important that you have a coordinated concussion management team, the primary care physician, the emergency room doctors as they see them, concussion specialists, school nurses, athletic trainers. A lot of people that you'll see presenting today are very helpful in treating the different domains. The role of the school nurse is super important. We're going to talk about I'm going to talk a little about the role of the school nurse, and then Becky's going to come back and talk a little bit more about the role of the athletic trainer. But school nurses see them right in the beginning, and it says this quote I really like: concussions have a more serious effect on a young developing brain and needs to be addressed correctly. Proper recognition and response to concussion symptoms in the school environment can prevent further injury and help recovery. So when it's recognized right away and they get some intervention and some treatments right from the beginning, they really have better prognosis. school nurses can help in so many ways. They're really boots on the ground, that they see it, and if they can get a plan in place right away, then we can really get some interventions for the student. Also, they are very good at educating teachers. Sometimes teachers aren't on board right away, getting and advocating for our students. One study showed that only 30 to 50% of schools had a policy on what to do with these kids when they come back to school. And I think if you're a school nurse and your school does not have a policy, or your school doesn't have a policy, that this is something you really need to advocate for. See what you can get done and get in place. And one of the greatest barriers that our school nurses face is that they don't have communication with the healthcare provider. So if you're a provider and you're a PCP and you see a concussion, really ask the student, ask the parents, what school do you go to? Who is your school nurse? And be sure that you're getting an email or a text or a fax to the school nurse letting them know that concussion took place. They shouldn't find out because the student comes to their office because they're not feeling well. It's really nice if they know what's going on. And I'm going to turn the time back to Becky, and she's going to talk a little bit about the role of the athletic trainer.
Well, now that we understand the role of the school nurse, what's the imperative is that the school nurse and the athletic trainer work together. And this is imperative for the success of our students and our student athletes. So getting back to the role of the athletic trainer's role, one of their primary roles is education. We need to make sure that we're educating everyone. We need to educate our student athletes on the effects of a concussion, recognizing signs and symptoms. We need to educate our parents on the same things. Understanding and educating our counselors, our teachers, our administrators on the return to learn plan. So education is key to the overall success of having a return to learn plan. We also might need to help empower our athletes to advocate for themselves if they do have a concussion. And in some situations, we might actually have to be the advocate for the athlete. We will also help coordinate with school personnel and parents, guardians, as far as the care needed for the students. We will monitor those signs and symptoms over time. And then when we get to the point, we will also coordinate our return to play plan. With this helping our student athletes, there's many times that when we tell our athletes, you can no longer play your sport until we're recovered. A lot of times we're taking that identity of being the athlete away from our student. And that sometimes can have a very bad effect on those students, and we end up, they become depressed, they're not wanting to stay involved in activities, they fall behind in school. So with this, as well as what Dr. Streeter and Dr. Moe have said, integrating sub-symptom activities is key to keeping these kids involved. So having that education component with them and saying, hey, we're still involved, we're still doing things, you're still an athlete, we're getting better, our ultimate goal is to get you back. We don't want to lose those students. So integrating those sub-symptoms activities is key. We also need to make sure that our athletes are honest when they're reporting to us signs and symptoms. Again, those students who do have a significant impairment, they don't want to be hurt. They want to be better. So we want to make sure that they're honest with reporting signs and symptoms and allowing us to give them the help that they need. We need to make sure we also have open lines of communications across the board with parents, teachers, administrators, and our athletes and coaches. And we have buy-in from all of the parties involved. Now this is the new caveat for this year. How do we make it work in a virtual world? People are still going to sustain head injuries. We will still follow our same steps, especially with our sign and symptom assessment. With this, as Leslie said, is we have to make sure that we are communicating. So if you have a patient come into your clinic, we need to make sure that we're communicating with that patient and asking questions. Are you attending school virtually? Are you attending school in a hybrid? Are you attending school in person? And let's make sure that we're monitoring the activities and the accommodations that we're requiring or requesting of our students and determine what are their sub-symptom capabilities. And stress that when we're working with these students that they maintain working at a sub-symptom threshold. Now with this, it's going to be a trial and error. We're all learning new things these days, and having a student sit in front of a computer screen for 6 to 7 hours out of the day might set off multiple triggers. So again, going back to the communication component and making sure we're communicating with the school, we're communicating with the parent, that we're having the follow through with everybody involved, that will again help with the successes of our program. But once we understand that, monitor and adjust those accommodations as needed. So very briefly, here's some of the resources. I know Dr. Moe said that these will be on the Spark website for you. I think we do have the ability to open it up for questions at this time. Okay, so what about driving and when can they drive again? Looking back at sign and symptom assessments, balance capabilities, things along those lines. This is really going to be one of those subjective things that you need to do. If you're having them do a balance best test, or if you're looking at some of their VOMs visual things and notice that we're having issues, driving definitely would be something you would want to avoid at those times. And again, with younger kids, it's difficult because driving is their lifeline. So if they're representing and having some of those problems, then your driving definitely would be off the table. The second question was, we mentioned that we have an assessment on the students because they're an athlete. What about other students? We do give the capability of the school nurses to utilize the student self-assessment. They may use something a little bit more abbreviated. Again, our policy is for our entire district, K through 12. Some of these situations that we had is, how are we doing a sign and symptom assessment with a first grader? That is very different than doing a sign and symptom assessment with somebody who is in high school. So school nurses do have the capabilities of doing those assessments.
Becky, can I go back and address the driving?
Yes.
A little bit more about driving. When can they return to drive again? Driving is a lot of components. What's the reaction when we do the cognitive testing? What does the reaction time look like? Also vestibular ocular. If you can't turn your head back and forth like this without getting really dizzy, you can't drive. So we're looking at their, again, function. What's their reaction time? What's their visual function? What's their vestibular function? And if it's maybe a young student, 16, that just got a driver's license, I'm not going to let them go back to drive as maybe a 50-year-old who's been driving for years and years. We may, and just like anything else, we'll probably ease them back into driving if they're not allowed to drive. For instance, driving with just in familiar neighborhoods in daylight hours, like just from your house to your school or just to your job, but really not doing a lot of driving right away.
All right.
Thank you, guys. Thank you.
Thanks, Dr. Moe.
All right, a big thank you for Becky and Dr. Streeter for that wonderful presentation. And thank you for all you guys do in the community as well to continue to move, return to learn, and return to work forward. I'd like to introduce Dr. Balaji. Arvind Balaji is a pediatric sports medicine doctor. I'm very pleased to announce that we were fortunate enough to have him join our team over at Spark, so he's one of our new physicians there. He did his residency at PCH and his fellowship at CHOP, Children's Hospital of Philadelphia, and I know some of those folks are probably tuned in too and excited to see him. So he's fantastic, and he's going to be talking about return to exercise, return to play, return to sport today, and some of the concepts there. So thanks for being here, and thanks so much.
All right. And I want to thank Dr. Moe and Spark and TMC for giving me the opportunity to talk here, and pardon me as I try to make sure I'm doing it the right way. My name is Arvind Balaji, and it's an absolute pleasure to talk to you guys. I'm hoping that we have a good mix of different sorts of participants in our audience: athletic trainers, primary care doctors from all sorts of backgrounds, residents, fellows, and I'm hoping that this talk will be building on the last two talks that have been given so far, as we talk about a topic that I'm very, very interested in and something that I'm passionate about, which is getting the concussed athlete back to the field. So I'll talk briefly about just a couple of objectives I have here. I want to talk about the most common neurological function of the brain that's affected by concussion, which is, again, like I mentioned, going to be building on what we've already talked about. I'll talk about a system-based approach about bringing the concussed athlete back to play after concussion. And then we'll touch base on strategies and pitfalls of the rehab process related to concussion. So like all things, we're going to start with a case, and I hope something about this case will hit home for everybody who's watching right now. So imagine that you are an athletic trainer on the field or a sports medicine doctor on the field, and you have a 15-year-old male soccer player who collides with another player head to shoulder during a scrimmage and falls to the ground. Now, he's slow to get up, and he's noted to be wobbly, and he comes off the field, and the athletic trainer evaluates him and feels that he's slow to respond to questions, so they don't allow him to return back to the game. He is held out of practice for about a week, and then prior to the next scrimmage, he says that he's feeling all better. So, of course, you all can probably imagine his question is going to be, hey, can I play? Now, a lot of you may already know the answer to that question, but for those who don't and who want a little bit more insight about how to answer this question, right now it's totally okay if you think your answer is going to be, I don't know. But by the end of this talk, I hope that you understand that you should confidently say that you don't know yet, and we're going to talk about that. So, Dr. Mo has already talked about this, but I just wanted to touch base and use some of the words that I'm familiar with using. Whenever I speak with patients about what a concussion is, I tell them that it's a shaking injury to the brain that doesn't necessarily require loss of consciousness, like Dr. Mo has already said, and it also doesn't require direct trauma to the head. So a whiplash mechanism where the brain undergoes a shaking mechanism without actually hitting anything is sufficient to cause a concussion. And of course, as he's already touched on, the imaging studies that we normally do, like head CTs and MRIs, after the injury don't show any abnormalities. The brain looks normal on pictures. However, the function of the brain is definitely impaired. And the symptoms generally onset within 24 hours after the injury, usually even shorter than that. And the symptoms can be a wide range, as we've already talked about, but I've listed a few. Athletes may say they feel a little bit slowed down in answering questions and reaction times. They may complain of headaches, dizziness, feeling nauseated, having fatigue, feeling lightheaded, dizzy from a standing position. These are all consistent with symptoms of concussion. So as we talk about, this is one of the slides that I really want to hammer home. The domains that are most commonly affected by concussion are exercise tolerance, or to be more specific, exercise intolerance, the visual vestibular system, the cognition system, and the mood system. These are the four that we're going to touch base on during my talk today. And the main tenet of concussion rehabilitation and bringing an athlete back to their sport is that all domains must be addressed and rehabilitated before the athlete can be returned safely back to their sport. So first we'll talk about exercise tolerance. And there's been a lot of evidence already that talks about exercise as medication for the brain. A lot of great work has been done by Dr. Letty and his group out of Buffalo. For instance, this paper here talked about how when patients are exercising, there's going to be a buildup of carbon dioxide and there's going to be changes in blood flow to the brain. Now, when you have a healthy brain that hasn't undergone a concussion or a traumatic brain injury, the ability of the brain to adjust to the changes in blood flow demanded by the body during exercise is great. However, when the brain is recovering from injury, it doesn't know exactly how to regulate its own blood flow in order to take care of the metabolites like carbon dioxide and those sorts of things. And this inability to regulate its blood flow informs the intolerance that concussed patients have when they're trying to exercise. So the main salient points I wanted to talk about is that a brain that is recovering from concussion has a feature of autonomic nervous system dysfunction. So the blood flow to the brain is not quite where it needs to be in order to handle not only functions of regular life, but also functions related to exercise. So we know the brain is going to be important in order to deal with breathing, managing the heart rate, and managing carbon dioxide, just to name a few. All of these are going to be affected in the concussed patient, which is going to cause him or her to suffer symptoms when they're trying to return to exercise. So one of the main questions that most people would probably have is, well, then is it safe? Is it safe for the concussed patient to exercise? And if you looked at older data, you might wonder that it's probably not safe because there have been studies that show that both in animal models and human models that forcing athletes to do early and high levels of exertion soon after their injury seemed to cause them to take a much longer time to recover. But newer evidence has shown that maybe there isn't an absolute rule about not returning patients back to exercise. Maybe there's safe levels. This study that was done by Dr. Letty and his group in Buffalo was a randomized controlled trial. This was the first one that took adolescent athletes that had suffered a concussion and exposed them to a graded return to play protocol in the sense that they weren't asked to do high exertion, they weren't asked to do it early, but they were asked to do sub-symptom threshold exercise in a manner that they were able to do without causing symptoms. And it found that those athletes among the group that were exposed to this sort of treatment versus the control had a shorter time to complete resolution compared to those athletes that were in the control group. So this study, as well as others, informed the fifth consensus statement on concussion that was in 2016. And the highlights of that statement are that in the acute phase after a concussion, the first 24 to 48 hours are critical for brain rest. We generally don't want athletes, or really anyone that suffered a brain injury in those first 1 to 2 days to be doing too much in the way of exercise, as well as in the way of too much cognitive activity and things like that. However, after that 48 hours has resolved, we think that the acute phase has ended and that the brain is now receptive to stimulation at every level. And in the sense of exercise, we now recommend that we do some sub-symptom threshold early exercise, starting at a lower amount of time and then gradually building up regularly as the patient can tolerate it. Now, given these new recommendations, it might be nice to have some sort of guideline to inform how we bring these athletes back to a level of exercise tolerance. And there's many different ways that we can do that. This, for example, is the active rehab protocol we have at Spark, where the step 1 of the protocol is just light exercise, biking or walking on the treadmill or walking outside, just to bring the heart rate up to about half of what's maximal for that patient. And as you can see, steps 1 through 5 indicate that we're going to push the athlete as he or she can tolerate through the steps as they are able to tolerate it without exacerbation of symptoms. And step 5 is maximal exertion that they can possibly do with MDM, which is multidirectional movement. This, again, might be a different form of the same slide. This might be a little bit more familiar for the athletic trainers that are in the audience, where we have a graduated return to play, or RTP protocol, for athletes that are being seen by athletic trainers in the context of a high school. Again, we start with light exercise, and an athletic trainer is monitoring the athlete to see how they are responding to exerting themselves. And ultimately, as they pass each of these steps, the 5th step is returning them back to the sport. The progression through each of these steps is completely based on symptoms. So if an athlete gets to step 2 and they suffer symptoms of a headache or dizziness while they're trying to exercise or soon after, then they are not asked to progress past that symptom. They're given a day's rest. And the decision can even be made to go back 1 step to make sure that we're not pushing them too quickly. So pushing them too quickly kind of informs, what are the risks of the active rehab protocol? Well, really, there isn't any specific risk to the athlete if the concussion is the correct diagnosis, especially in the cases where they are being monitored either at a concussion specialist's office or with the athletic trainer themselves. The main risk that you might see is that the athlete exacerbates symptoms. One of the primary pitfalls of this situation is that if you have a high-level athlete who is conditioned and is expecting him or herself to perform at a high level, they need to understand and need to be coached that they are not quite ready to return back to the level of competition that they had pre-injury. And no amount of pushing through or getting through the pain is going to help them recover any faster. And in fact, it can make them recover slower if they induce too much symptoms while trying to get themselves back on the field. So the correct dose of medication to treat these athletes in terms of the exercise pathway is a graduated active rehab protocol based on symptom exacerbation. So that was the first domain we talked about, where the next domain we're going to talk about is the visual vestibular system. Now this pathway is also affected in terms of the concussed athlete. And this study that was performed by Dr. Master and her colleagues at the Children's Hospital Philadelphia took 100 adolescents and found that about 2/3 of them, maybe even more, 70% of them almost, had some level of visual abnormality that was detectable soon after their brain injury. And at least half of them had even more than one specific diagnosis related to the ability of their eyes to track fast-moving objects and to track objects near and far. So this is a diagram that details the VOMS physical exam maneuvers that we perform in our clinic, and athletic trainers are probably very familiar with that, in which we take an athlete and we ask him or her to track our finger through a whole host of different types of modalities in order to see how well their eyes move, how well they move together, whether they have significant nystagmus in any direction. And we also test the convergence of their eyes onto objects that are near and the divergence onto objects that are far, and how well their eyes can accommodate to different sorts of physical exam maneuver challenges. And the symptoms that are exacerbated by this exam inform us and tell us how well the visual system is working and how well the vestibular system is working in this specific athlete. So this paper that was published and this study that was done by Dr. Moe here found that those that were more symptomatic with this specific exam maneuver were less likely to have good exercise tolerance when we challenged them. And additionally, if their near point of convergence was 15 centimeters or greater, meaning that if they were not able to track in an object that was coming towards their eyes closer than 15 centimeters, then they had lower tolerance when we try to get them back to exercise. So we know that the system is involved in the symptomatic athlete with concussion, and it's also directly related to their ability to tolerate exercise. Additionally, it's important to think about that the eyes are incredibly important, as most people probably obviously know, in participating in school. The concept of even reading or note-taking is an extremely complicated mental task that involves eye tracking left to right across a page, keeping track of where you are on the page when you have to go to the next line, keeping track of where you are in terms of pages within a chapter, as well as paying attention to the teacher or whoever the person is that's giving the lecture, and looking up from the board and looking down at your desk to take the notes, and then to track your own notes that you write. It's a very complicated task, and if your visual system is not completely normal, all athletes that have an abnormality in their visual system are going to struggle in being able to perform their best in school. So we know that these eye tracking abnormalities are going to affect the ability of a student athlete in school, and from the previous slide, we know it's going to affect them in terms of their ability to tolerate exercise. So the big question is, what do we do about it? Well, much like the previous slide, we're going to rehabilitate these athletes. And athletic trainers, as well as our athletic trainer we have at Spark, are very familiar with different sorts of visual rehab processes that they can practice, and they could have their athlete in their office as well as at home practice these eye exercises in order to improve the visual system. And in much the same way I talked about before, a rule of thumb you can give these athletes is to allow them to do these exercises at home in as much as it doesn't exacerbate symptoms. Once they start having symptoms of dizziness and headaches while they're trying to do this, they should stop, take a break, and perhaps try again the next day. This is sort of a feedback loop that the athlete can be given in terms of guidance so that they don't overdo it with these treatments as well. So we talked about vision, vestibular, we've talked about exercise. The next we're going to talk about is cognition. And then specifically with the high school athlete, we're going to talk about how he or she is prepared or unprepared to return to the classroom. So this study that was performed by Dr. Brown, one of my former mentors at the Children's Hospital of Philadelphia, looked at how long it takes athletes to return to the sort of cognitive demand they need to be able to do after they've suffered a concussion. Now, as you can see on the slide, there are different levels of gradations and different levels of intensities that the population that they were studying was exposed to. And the long yellow line that seems to show that it takes a long time for these athletes to recover from their injury and to get back to normal is the line that expresses the most amount of intense cognitive activity. So we see that those that are exposed to too much cognitive activity way early on seem to take a long time to recover compared to their compatriots. However, the other three levels of intensity of cognitive activity all sort of heal in terms of their brain injury at about the same level. So the take-home message behind this is to say that there are safe levels of cognitive activity, as Leslie and Becky already talked upon, that the concussed athlete can tolerate without having significant prolongation of any of their symptoms. So there are ways that we can bring the student athlete back to the classroom in a safe way and expose him or her to stimulation from a cognitive level, asking them to take notes, asking them to read chapters, asking them to participate in classroom activities, that's going to be safe for their brain after brain injury, that's not going to be too much on them, and it's not going to overall prolong the process of getting them back to the field. So the question becomes, well, if you have an athlete that's concussed, are they ready to take quizzes and tests within the first week? Are they ready to talk about complicated tasks in the classroom? Are they okay to type up long papers and submit them? Are they okay to do big projects? Are they okay to work in groups? Of course, as we all know, the classroom is a very challenging place to be, and the demands of one type of class may be far different from the demands of another, such as the thinking processes that go into doing physics problems are going to be very different from English class as well as social studies and those sorts of things. So how do we protect the athlete? Well, at Spark we have, as Leslie talked about and Becky talked about, we have different color zones that we can put patients in order to help them protect themselves and to give schools guidance on what sort of cognitive activity the patient can tolerate. So the red zone is going to basically be, you can't tolerate really much of anything, you should take a full break from classroom activities, your brain is not ready to face this cognitive demand. And as you go past the color zones into yellow, orange, green, then we slowly ask the athlete as they return to the classroom to do a little bit more. And we ask them to do more not only to prevent them from falling too far behind in school and to protect their grades and those sorts of things and to foster their learning, but also because this is appropriate therapy for the brain. Exercise is appropriate therapy for the brain. Doing the visual and vestibular exercises is appropriate therapy for the brain. And school is also therapy for the brain. We want patients to be in school when their brain can tolerate it. We don't want them to do too much. We don't want them to do too little, but we do want them to participate in an active way. And we have manners here through these color zones in order to protect them. So as you go up, you won't be initially asking the athlete to do tests. You won't be asking them to take quizzes. You won't be asking them to type up long pages and do intense reading, but we do want them to participate in class. We do want them to listen. We do want them to try to take notes. We do want them to try to do some studying at home. But we try to give them as many breaks as possible that when symptoms start to be getting to be too much, they step away from that activity, take 5 or 10 minutes off, and wait for their brain to settle back down, and then return back to the activity. And so the main message that I want to send home is that is the way that we kind of approach the way that we bring students back to learning. Now, as Leslie and Becky have already talked about, there's some computer-based tests that have a lot of value in helping us assess in an objective way where an athlete is in terms of their ability to return to the school. So one that's very common and probably used across the country, if not the world, is IMPACT, which is very helpful for us if high schools are employing them for a baseline test. So before the start of any season, before any head injury, if we know what cognitive level the athlete is based on their IMPACT testing, it can help us give a target for where we need to bring them back to after they've suffered brain injury, because of course the post-injury IMPACT testing is going to be skewed compared to pre-injury. Additionally, Cambridge Brain Sciences, or CBS, has a whole host of modifiable online computer-based tests that can help us evaluate on many different levels where athletes as well as patients of all sorts of ages and cognitive capabilities are in their pathway to return back to normal function. So we will commonly use this in our practice in order to help us get objective data to justify where we're going to put these patients in their color zones based on how much cognitive activity we think they're capable of. And it is a lot of trial and error in the sense that we may ask an athlete to do too much initially, and he or she may have a prolonging of symptoms. And we may ask the athlete to do not enough, and when they come back to see us the next time, they'll tell us they're bored and they're ready to go back to school. But by and large, these two studies really help us figure out how to bring the athlete back safely. So the take-home message is that the athlete, before they can be brought back to the field, need to be ready to learn and need to be completely participating in their classroom setting without needing any accommodations of breaks or larger font or any of those sorts of things before they can be allowed to return to play. Now, the last domain that I wanted to touch base on was mood. We know that all patients that have suffered a concussion have some dysregulation of their mood after the injury as a consequence of the injury. And there's lots of studies, and I've just picked one that can show that adolescents that have had concussions suffer poor mental outcomes on the whole. And this is multifactorial, of course, meaning if you have a high-level athlete that's supposed to be a starter on varsity, they've suffered a concussion, and you pull them out of their sport and say they can't go back, that's going to have an effect on their mood right away. Additionally, if an athlete has had a week or two of symptoms and they're falling behind in school, the nurse is still not allowing them to return fully back to school, or their doctor that's following them hasn't gotten them back to school, they're falling behind on assignments, they feel a sense of pressure, especially if they're high achieving and are trying to get the best grades they can to get a good scholarship or trying to go to college. The level of stress that applies is going to have an impact on their overall mood and function. And lastly, the injury itself has been shown in some preliminary studies, and the knowledge is building in this, in that this injury itself is going to accumulate some metabolites that are going to cause dysregulation in mood overall. And so there have been some studies that show that pro-inflammatory cytokines seem to stay elevated soon after a traumatic brain injury. And this seems to be correlating well with depression symptoms that persist after the brain injury. And a lot of this has been done on patients that have suffered significant injuries in car accidents and pedestrian versus automobile accidents and those sorts of things. But the mechanisms still correlate well with those that have suffered injury in relation to sport. So we know that the mood is dysregulated from a standpoint of both stressors associated with the injury as well as the injury itself. So overall, what are the risk factors that we should be talking about? Well, football among high school athletics seems to be the highest rate of concussions across the board for obvious reasons. It's a collision sport where a lot of times an athlete putting on a greater hit to an opponent is something that we ask for rather than something that we try to prevent. So for obvious levels, football is going to have a high level of concussion. Those risk factors that Dr. Moe has already talked about and I'll briefly talk about that can lead to prolonged recovery are the younger athletes who have a harder time following the directions of removing themselves from exacerbating symptoms or exacerbating activities for symptoms tend to have a prolonged recovery. Those who have had prior concussions, especially those who have had a really long recovery from a previous concussion, may be considered at risk of having a repeat prolonged recovery as well. Female gender seems to predispose athletes to having a prolonged recovery, as well as those that have a concomitant mood disorder. So if you had anxiety and depression before your injury, problems with that as well as symptoms associated with concussion will tend to be longer after your injury. So the main message I want to send home is the clearance for an athlete to get back on the field after concussion is based on those 4 domains. And so from an exercise standpoint, they need to have completed the step 5 of the active rehab or return to play protocol. They have to be completely back in the classroom, participating at 100% with normal cognitive activity without any accommodations. Their visual oculomotor stability examination needs to be normal on testing, and they need to be symptom-free completely without the use of any medications, including mood symptoms, or if they have had lingering mood symptoms after the other 3 things have been addressed, then the mood disorder being addressed from a cognitive behavioral therapy standpoint and or a medication standpoint needs to be in place before we consider that athlete to be completely resolved from their injury and safe to return back to the field. Now, briefly talking about a lot of questions I think most people will have is, well, what are the long-term implications? How does chronic traumatic encephalopathy fall into all of this? How many is too many? Unfortunately, the reality is the literature isn't obviously clear about what is too much, what is too little. What we understand is that based on the information we have, there's no clear link between severity of concussion and a direct correspondence with developing chronic traumatic encephalopathy or long-term brain abnormalities. So a multidisciplinary decision is really what's encouraged, meaning the athletic trainer, the nurses, the parents, and the athlete all have to come together and talk about, well, you know, this injury took 6 months or this injury took 9 months. Do you really want to go back to a sport where this might happen again, and the next time it happens, it may just take just as long, or it may take even longer? And some people don't really even get back to a normal baseline. The different mechanisms connecting their neurons has changed in some fundamental way that we don't yet know how to measure, and we know their brain isn't working normally in terms of how it was before their injury compared to after their injury, even though they're able to return to their classroom and they are having a normal exam. We know fundamentally they're a little bit different if their injury was significant enough than they were before, and that may inform how safe it is for them to return back to their sport. And that's not really a decision that, as a medical provider, I can say one way or the other because the literature isn't clear on that, but it is a decision that parents need to be counseled on, the athlete needs to be counseled on, and a longer, deeper conversation involving multiple people that are involved in the patient's care need to have a say in deciding ultimately what's best for the patient. So I wanted to give a special thanks here, Dr. Mo at Spark and Dr. Grady and everybody at CHOP that has helped me amass the sort of knowledge to deliver this presentation as well as to give me the guidance on these sorts of things. So I think now we're available for any questions that people may have. And I see a couple on the board here, and I'll be happy to answer them. So the first question here is, does Spark take referral from adults with prolonged symptoms? Absolutely. We are a concussion group that sees athletes as well as non-athletes. We'll see patients of any level of complexity. We'll see patients of any age, all adults. I myself am taking care of plenty of adults that have suffered brain injury and concussion or are having prolonged symptoms, whether it's acute or it's been a month, 2 months, 3 months, and the patients are not getting better. We'd be happy to see patients of any age. The next, what goals should be included for exercise rehab in patients whose symptoms are prolonged and they are not receiving the appropriate treatments to address vestibulo-ocular symptoms? So that is an excellent question. So exercise from an aerobic standpoint is really crucial for brain recovery, and it helps the brain recover in all 4 of the modalities. So exercise is good for the autonomic nervous system, it's good for visual vestibular, it's good for mood, and it's good for cognition. But that's just aerobic exercise. In athletes that are having prolonged vestibulo-ocular symptoms, the best step I would say is to speak with either a concussion specialist, a physical therapist, or a athletic trainer who is comfortable in doing vestibular testing and visual training in order to get athletes specifically addressing the eye exercises that they need to be working on both in the office as well as at home in order to improve the activity of the visual and vestibular system. And I think that may be all the questions we have. Oh, we got a couple more. Is ibuprofen safe in a patient that is concussed? Excellent question. If the diagnosis of concussion is certain and there isn't any concern for a concomitant bleeding disorder, there isn't any kidney injury and those sorts of things, ibuprofen taken in appropriate doses is safe for a concussed patient. The caveat I have is that from my personal experience, I haven't always found ibuprofen to actually help with the associated headaches and migraines. Some patients say they do, but a lot of them say it doesn't really help. So it is safe if it's taken at the appropriate dosages, but don't be surprised if your patient or athlete says that it's not really helping or doing anything, because we know that the best way to treat the headaches associated with concussion is to remove them from the activity that's exacerbating symptoms. Next question, should patients initiate rehab for vision before symptoms are resolved and only stop if exacerbation occurs, or should vision only be addressed with no baseline headache and dizziness are present? So that's an excellent question, and I'll be pretty blunt. In terms of taking care of athletes, there's really not going to be, or really any concussion patient, there's not really going to be a time where they're going to come into your office and say, I don't have a headache or dizziness, and you'll still feel the need to address their visual and vestibular system. So what I mean by that in general is there's never going to be a perfect window to treat these athletes with these exercises for vision and the vestibular system. So if you keep waiting for symptoms to get better and get better, you'll realize that you're just prolonging the recovery of the athlete. So I would say initiating visual and vestibular exercises early is safe to do, as long as you can give them the guidance that, I know you don't feel well. Let's say your crumminess factor is a 3 out of 10. So the 3 incorporates the dizziness, headaches, whatever. I know you don't feel well. So I want you to do these exercises anyway, because it's going to decrease the length it's going to take for you to recover from your concussion. I know you're not going to feel good doing them. So go ahead and do them until you get more than 2 points above on your crumminess scale. So if you get above a 5 out of 10 in terms of, man, this is really killing me, I can't do this anymore, that's when you stop and take a break. And if you feel up to it, you can try to get back to it again later on in the day, or do it the next day. So you're never going to have an athlete that's perfectly ready to engage in these situations, and it's better to just give them guidance in, I know you're not going to feel well doing this, but this is really the best thing for you, and give them guidance on don't overdo it. We'll give you a scale that you can follow, and as long as you fall in that scale, it's very safe for you to do, and you will overall recover. And I think that concludes all of our questions, and I'll hand it on back to Dr. Mo.
All right. Thank you so much.
Of course.
Dr. Balaji, that was a wonderful presentation. Thank you. I don't know who did that segment last year, but that was way better. That was me. Yeah, that's right. That was me. So anyway, fantastic presentation. Thank you. It's my pleasure to announce Dr. John Miner. Dr. Miner trained at Boston Children's and is really, particularly on the musculoskeletal side of things, and what he's going to talk about today, cervicogenic, just an absolute talent, and we are so fortunate to have him at Spark. And he has many of my patients who continue to have cervicogenic problems as part of their concussion. I end up passing over to him, and he's also very talented with the ultrasound, so he's able to do a lot of our trigger point injections, a number of which are under ultrasound guidance, and just a fantastic physician. I'm very excited for his segment here today on cervical evaluation and management. So John, thank you for being here.
Thank you, Mo, and good morning to everybody. So this morning I will make sure that this is a relevant topic to the entire audience. Ultimate goals here, so regardless of your background, whether you're a school psychologist, a athletic trainer, a physical therapist, or a physician, I'll make sure that this talk is relevant to you regarding the neck. I'll jump past all of these objectives. We will circle right through them. So ultimately, the mechanism of concussion is complex. We know that there are some angular forces that are applied to the brain that result in concussion. So this is kind of funny looking at this slide of kids hanging upside down. But ultimately, the concussion injury is caused by angular forces on the brain that in essence spin the brain and result in this complex pathophysiologic process of stretching nerves and causing symptoms. And of course, in the course of this mechanism, in order to apply these angular forces onto the brain, the neck also can sustain a significant injury as well. And so looking at a few interesting slides, sports-related injuries, we know that concussions can result in any of these about to occur injuries, head-to-head contact, body-to-head contact as well. So many of these injuries may result in a concussion injury. And while we might think exclusively of the athlete, it's also important to recognize that concussions will occur in many of our non-traditional sports, the weekend skier, cyclist, anybody out doing weekend activities. We have lots of injuries that will occur around the house, slip and fall down the stairs, slip and fall on ice, motor vehicle accidents, which our clinic is very familiar with, and then not to forget even domestic violence as a potential cause and result in concussion. This talk specifically is relevant to those patients who may have prolonged symptoms and don't seem to be recovering from their concussion. So we sometimes wonder when the patient comes in and they're several weeks into recovery, is this truly concussion or is there something else going on that is causing these concussion symptoms? So here's a pretty long list of the differential diagnosis of other conditions that may be underlying or may be going on and causing the patient's concussion symptoms. And while all of them are possible, and we ultimately will do some evaluation to confirm them or treat those conditions, I'll be addressing more of your cervicogenic headaches, neck symptoms, neck injury, and how it relates to post-concussion syndrome, or PCS, or now prolonged post-concussion symptoms. So what's interesting, and I'm sorry I didn't give you the resource of this article, but there is a significant overlap of your concussion symptoms that really overlap pretty clearly with many of the cervical or neck symptoms as well. And you can see on this slide here that many of these common concussion symptoms, headache, dizziness, ringing in the ears, irritability, sleep disturbance and sleep problems, having blurred vision or vision problems, and neck stiffness can be classified either by concussion or cervical injury. As we start looking through the list more, the ones that are common to both, balance disturbances, having memory problems, memory problem or cognitive deficits, so recalling information, feeling slow, anybody with decreased cervical range of motion, that can be the concussion. I apologize, my slide transferred a little bit different, so I'm trying to read these a little bit separately. But when we see people with decreased range of motion, a lot of times that really is the cervical injury. But anybody with decreased isometric neck strength, it could be concussion or the cervical injury. When we see somebody who seems exclusively depression, that might classify more as your concussion, or somebody who's having more attention deficit problems, that could be either actually cervical or concussion. And when we talk about memory deficits, a lot of times this specific article talks about amnesia of the injury versus current problems with memory. Many times that's actually in relation to the concussion injury versus a cervical injury. So as we look at and try to compare concussion and cervical injury, we know that the concussion, as I described, is this complex pathologic process that is induced by mechanical forces affecting the brain, and the mechanical forces of the angular forces that are stressed on the brain during the concussion injury. And then the cervical injury, as we describe and define that, it really is a persistent impairment and persistence of impairments that are caused by a dysfunction of the somatosensory system of the cervical spine. So as I described, the head and neck go through stresses, and that winds up also affecting the neck. So what we believe is the strain that's placed on the neck during the mechanism of injury results in soft tissue injury, muscle strain that affects the neck and thus can bring on concussion symptoms. This strain, as I describe it on the neck, actually affects the afferent pathways, so the messages that are being sent to the brain that are supposed to be relaying information from the neck to the brain about proprioception, where the neck and head are in space, and what's going on. And of course, in the setting of a concussion, you can have both of these that occur at the same time because of that common mechanism of injury. So when should we start considering a cervical injury in a patient, whether it's a student at school or in one of our medical offices? Anytime that we've got a patient with prolonged symptoms, this could be 4 weeks out, 8 weeks, 12 weeks, even sometimes we see those patients who are years out from their injury and still having symptoms. I would consider it in anybody who has had a plateau or a slowing of their recovery, since traditionally we will see the symptoms peak and then gradually over time, if we're doing all the right things, the symptoms will, in a very linear fashion, typically resolve and go away. So in that patient who the symptoms have really slowed down, maybe they aren't making progress between visits, start considering the neck. Anybody who seems to have persistent visual or vestibular, so balance problems or intolerance, people who aren't tolerating screens, whether it's a phone, a tablet, a computer, people who can't tolerate watching TV, even appropriate feet away from it or distance away from it, and then other times patients who seem to have dizziness when they're walking or can't tolerate being a passenger in the car, hitting little bumps and making very simple turns on the streets. These people may be evaluated and should be evaluated for cervical injury. And then anybody who seems to have chronic neck and shoulder pain, we should do a little bit of a workup and evaluate for the contribution of their concussion symptoms related to the pain that they can point to in their neck and shoulders. And finally, too, those patients who seem to have significant headaches and they're not responding well to other treatment, these might be people who are really having really significant cervical symptoms and warrant evaluation and aren't going to make progress until we actually treat their neck. So briefly here, we've got the cervical injury pathway. So how does this overload on the brain occur? So we have 3 redundant systems relaying information to our brain about proprioception, giving us information about our surrounding and what's going on. And our brain relies on information from our eyes. It relies on information from our ears and inner ears, especially that vestibular system. And then there's supposed to be congruent information that is coming from the neck. And many times, if these 3 pathways, these 3 systems that are sending information to the brain, if there's not congruent information being relayed to the brain, it can bring on any of your host of concussion symptoms. And as we talk about cervical injury and what can occur with that mechanism of injury and a whiplash injury, I won't get too far into facet joint injections, but we will see, because of the leaving the nerves that are exiting at these various levels in the upper cervical spine, we can have people who wind up having cervical symptoms because of irritation of these nerve roots. And listed in this order, we commonly see C1, C2, C2, C3, and then finally that C1 between the occiput and C1, and then C3, C4 in order of most common to least common facet joint involved with the mechanism of injury. This also, since we have that C2 nerve root that's leaving between C1 and C2 as the most common spot, we many times see, or I definitely see them, with greater occipital nerve complaints, pain that seems to originate at the base of the head and travel into the head, causing headaches, and perhaps that explains why the greater occipital nerve, which is C2, is so commonly affected in concussion and the injury. So now let's get into a little bit more of the evaluating and treating, and here's just an example, and you could really throw almost any patient who comes into our office with prolonged concussion, you could throw their story up here. So for example, if we had a 16-year-old female, any mechanism of injury, it could many times be a car accident, but a sports injury, a slip and fall, They're 6 weeks out from injury, not feeling like she's making much progress. Maybe she is still having significant headaches and both light and noise sensitive. She can't tolerate exercise or cognition. She's feeling nauseous, dizzy. A lot of these patients are still, they describe moodiness. They're sad, they're irritable, perhaps in school for just a couple of hours a day, and admits that they're not tolerating that very well. And we could already have them working with physical therapy or their athletic trainer at school, and they're just not making progress. This is definitely the type of person who should warrant cervical evaluation and get you starting to think about the neck. So let's now talk about evaluation of the cervical spine. What do we do test-wise to help identify a cervical injury? So I've got 4 different tests here that we will run in clinic and might give me an indication that we've got a cervical problem that needs to be addressed. So this first test is called the joint reposition error test. And what we do is we'll use a laser light and have that projected from the patient's forehead. We'll have them position the target of the laser on a target that's several feet away on the wall. And then I have the patient close their eyes. I'll position their head 30 to 45 degrees in each direction. So we'll test in each direction. And without opening their eyes, I try to have the patient reposition their head to that starting position. And a lot of times I'm using an 8.5 by 11 piece of paper with a target. And if they're off of that piece of paper, it is an abnormal result. And if they're significantly off of that piece of paper, then it really indicates a more significant injury. This test is really assessing for spindle damage of the nerves inside of the muscles, and many times these patients may just need more neck proprioception retraining. Next test is your smooth pursuit neck torsion test. So with this test, as this image demonstrates, you can have your patient turn their head at least 45 degrees. I usually try to reach their end range for rotation without causing any significant pain. And then we'll test their extraocular eye movements. And what we're looking for is any complaint of dizziness or feeling like they're a little bit unbalanced as they're doing this exercise. And again, we're overloading the eyes and the neck and sending information to the brain from those 2 systems and bringing on abnormal symptoms. If this patient does have dizziness or they feel a little off or their headache gets a lot worse, manual therapy or gaze stabilization exercises would be very helpful. And I would even include with the manual therapy, injection therapy could be a great option. The head and neck differentiation test. So in this test, I'll have my patient sit on a stool that we can easily rotate. I try to get them positioned in a place that their feet are off the ground so that we can very slowly swivel that chair or that stool. You want to move the stool very slowly so that you're not moving them too quickly to cause dizziness because of the vestibular system. So with a very, very slow move and rotation of that stool, they're supposed to keep their nose or the laser light pointed at a target so that as they're turning, they're stretching their neck. And if they complain of any kind of dizziness, balance concerns, headache, that is a positive result, and they would benefit from any form of head and neck differentiation exercise training. And again, any of these patients would benefit typically from injection therapy or soft tissue work. And finally, we do a cervical flexion rotation test. So we have our patient laying supine. We'll flex their head to a comfortable end range position and then rotate them. And if this patient experiences dizziness, then we will treat typically more with manual therapy of the neck. And this would also be another one great for any other soft tissue work, including injections. As I'm evaluating my patient, I also will evaluate for headache and where they're feeling their headache, because so many of their headache symptoms are actually arising from their neck or their shoulders and being transferred or radiating and referred to other specific regions of the brain. So with this diagram, we can identify areas and specific muscles that might actually be causing their headache symptoms, and thus we can also address those muscle areas and the muscle groups specifically. Once I've identified the muscles that I would like to address, then we will address with some form of injection therapy. So as we talk about trigger point injections, there are two traditional forms of trigger point injections. Most people will perform injections with cortisone and an anesthetic agent like lidocaine. Some trigger point injections are anesthetic agent only. And then I have found significant results by using prolotherapy, where we use dextrose or sugar and mix it with the anesthetic agent. The theory behind the dextrose is that it is pro-inflammatory, and so these muscles that are chronically strained, we can actually get those muscles to relax and repair themselves through the use of the dextrose and stimulating that inflammatory process. Some of the specific locations that I address, I would say regardless of comfort level, this is an injection that is very easy to perform, is the greater occipital nerve injection. And if there was one injection that can absolutely be performed without ultrasound guidance that I perform, this is definitely it. With regard to the greater occipital nerve, I typically will palpate the region on this image on the right-hand side. You can see where the needle is attacking midway between the greater and lesser occipital nerves. I will actually palpate there first, and you can identify this location by palpating the mastoid process, having a finger at the midline, and then identifying that location approximately halfway between those two sites. And a patient who has pain there or just under the edge of the occiput is a positive test. I get a number of patients who, as this image on the left demonstrates, you press there and patients will complain of sensations that radiate up into the back of their head or around the side of their head. That's my positive test for knowing that I would like to perform a greater occipital nerve injection. Next, probably the second most common injection that I do is a levator scapula and trapezius trigger point injection. Looking at the image on the right, you've got the trapezius muscle highlighted, and that overlies all of the muscles that you can see on the right-hand side of this anatomy diagram. And the levator scapula that is running from the superior medial corner of the scapula up into the neck, I'm able to identify that muscle both on exam, confirming that that is tender. Oftentimes you can palpate a cord right through that region of the back of the shoulder. During my injection, I'll actually line my ultrasound probe up with the levator scapula and inject inferior to superior. I can track my needle right down. I inject a fair amount of my solution into the trapezius and then into the tissue plane between the levator scapula and the trapezius. Also, portion of the trapezius muscle that I will also address, particularly the lateral aspect of the trapezius, palpating more laterally. If I can identify a spot that's pretty tender, and again, you can many times feel some cords through the muscle, it gives you a good area to palpate. I perform a simple injection with the ultrasound probe over the top of the shoulder and go posterior to anterior and inject into that area of the trapezius. The rhomboid muscle, this is probably the third most common injection that I will perform, and on palpation you can identify the palpable cords and identify the specific trigger locations, whether you want to mark them with an X or many times just palpating, you'll leave a little red area of the skin and then be able to come back through. I prefer to perform this injection with ultrasound guidance, and I'll also be able to address a little bit of the trapezius, which is overlying, and then also inject into the rhomboid muscle. Other locations that I have injected, we'll see, sorry I don't have a slide for this, but many times I'll also inject the lateral pectoralis muscles, just because a lot of times the pectoralis is going to be tight, contracted, as it's pulling against all of these posterior muscles that are retracting the shoulders. So I'll get a lot of people with some anterior shoulder pain as well, and that's another common area that I will address. Rarely, but relatively common still, I have addressed the superior aspect of the sternocleidomastoid, upper trapezius, all at the same time, as well as the paraspinal muscles more superiorly. So not everybody's ready for trigger point injections. I don't know any patient who walks into my office and is looking forward to being poked by a needle. And we have a lot of patients who are looking for other options first. And I, of course, will reserve injections for those who are ready and feel, and we feel the only option that's really going to get them moving along is injection therapy. But what else can you do before poking patients with a needle? So physical therapy, which oftentimes we are sending our patients to right away. At physical therapy, any kind of soft tissue work and joint mobilization is incredibly helpful. Graston technique can be very beneficial, as well as things like an suboccipital release. Dry needling, for those physical therapists who feel comfortable and perform it pretty regularly, dry needling is very helpful. And I would say many of these same areas that I will inject, levator scapula, trapezius, rhomboids, the suboccipital region, those would be great areas to attack with dry needling. Physical therapy will also perform strengthening and proprioceptive exercises to help retrain the eyes, the balance, and the afferent nerves in the neck as well. Osteopathic manual manipulation can be very helpful, so a doctor of osteopathic medicine performing suboccipital releases, as well as other soft tissue releases can be performed. I like offering and advising patients on techniques like acupuncture or acupressure. For those patients who are not interested in being poked by a needle, acupressure is perfect. Massage therapy can be very helpful, and we get a lot of parents and patients asking about massage therapy. I would absolutely support doing that. And then even craniosacral manipulation, working with a craniosacral specialist can be helpful. In summary, we know that concussions will occur. And I would encourage you, anytime you've got that patient who is weeks and sometimes months into recovery and not making progress, they're still having their prolonged symptoms, consider the neck and the cervical organ or cervical region as an origin of their pain, and try to treat them with some of these options. And then consider a referral for cervical focus therapy, and this again would be working with a physical therapist, sending somebody to osteopathic manipulation, or sending somebody to a specialist like me for trigger point injection therapy. At this time, I've got a few minutes. I would be happy to take a few questions. So first question here, how would I respond to questions about chiropractors? And I would classify a lot of the low energy mechanisms and methods that chiropractors will use, treating them very similar to what, say, a physical therapist or an osteopathic physician will do. I think some of these low energy manipulations can be very effective and helpful. And working with a chiropractor or an OMM specialist, it may require several visits to go in, but you should, as long as you're seeing some benefit, I would encourage the use of a chiropractor. At some point, these patients may still require some additional therapy, whether injections or physical therapy, to really augment those manual manipulations. All right. Well, it's been wonderful talking, and we'll bring Dr. Mo back on.
Thanks so much, John. Appreciate it. Wonderful talk by Dr. Miner, as usual. And we're going to now take our break. We'll reconvene at 10:15, which gives us, we're right on time. Gives us about 15-minute break. And we will be back with Dr. Amy Tees, who will be talking about headache and migraine management and concussion. Very excited for her talk. So thank you. Hi, thank you for coming back. I hope you guys all had a chance to enjoy your break. Up next, we have Amy Tees, who's going to be speaking on headache management, and in particular migraine management and concussion. As I alluded to, based on the research, seems to be our #1 phenotype that we see. So very important talk. I'm very excited to have Amy Tees here. She is one of the nurse practitioners over at Center for Neuroscience, and a headache specialist, I believe one of 11 in the state. So very unique in what she can do, and certainly my go-to for a lot of my refractory, very difficult post-concussive migraines. So very excited to have her here, and here's Amy Tees. Thank you.
Thank you. Thank you so much for asking me to speak. I do have a couple of disclosures. And so my disclosures are Amgen and Novartis, Allergan, which just changed to AbbVie, Supernus, Eli Lilly, and Promeus. I also am a sub-researcher for Eli Lilly currently. So we'll go ahead and move on here.
You guys are good for physicals.
So mild traumatic brain injury, which we've discussed at length here, as well as concussion, includes concussion and does not require direct contact with the head or neck and can be secondary to forces that disrupt brain function. I'm going to go ahead and quote one of my dear friends, Bert Vargas, who's a concussion specialist and has since left clinical medicine and gone into pharma. Headache is the most common symptom of mild traumatic brain injury and is one of the most disabling long-term sequelae of head injury in those that have prolonged course of recovery. Most common headache type, as we alluded to earlier, is migraine, and many other headaches have been described, including cervical tension type and traumatic autonomic cephalgia, which incidentally is my favorite headache disorder. So over here we're seeing a picture or one type of a migraine aura. However, there's many type, and actually only 30% of migraineurs develop aura with their migraine. So these are some of the questions I ask when I'm interviewing a patient and talking about their history of present illness. So is the migraine, or is there associated symptoms with photophobia, so bright lights, sound, nausea, vomiting? Are they avoiding physical activity? Is the headache onset sudden? Is it associated with coital activity or sexual intercourse? Is it worse with exertion? Does it get worse with activity? And what kind of activity kind of sets that off? Is there a change in how it recently started from their previous headaches? Many of our patients had headaches prior to their injury, but is it different now? Does it feel different to them? Are there autonomic features such as ptosis, scleral redness, tearing, nasal congestion or runniness, ear pain, ear redness, warmth? How does that feel different to them? Is there a positional quality? This is especially important. Is the headache much, much better with laying down, worse as the day progresses? And as we heard from Dr. Miner, is there a neck component, and how much of that plays into this? Is there a visual component? Is there blurred vision, aura, visual loss, transient losses, and then the vision comes back? What kind of associated symptoms are here? This is our red flags that we really want to pay attention to. Are there tender spots along the scalp, especially occipital or temporal artery? Is there TMJ clicking or grinding? And especially, is that different? Is there neck spasms or difficulty turning or positioning of the neck? Again, as Dr. Miner alluded to. Carotid exam and cardiac exam, especially if that's new or different. Are there reflexes abnormal, especially hyper or different from one side to another? Is there gait spasticity or irregularity, especially different from how they walked previously? I realize there's a lot on this slide, so bear with me, but this is Dr. David Dodek. He's up at Mayo Clinic, and he designed kind of a simple questionnaire, if you will. I realize it doesn't look simple, but bear with me, to kind of think of, again, our red flags. So SNOOP 5. So S being systemic or secondary risk factors, neurological deficits on exam, onset being, like we talked about, the type, older age, so some of the things that we have to think of that may come with older age, progressive headache history, like we talked about, presentation or character, positional quality, precipitation with Valsalva or exertion, so some of the things we might think about if that occurred, pulsatile tinnitus, again, some of the things we might think about if that occurs, and pregnancy, because that might include a hypercoagulable state as well as other risk factors associated with that. Testing. So these are all the things we always want to do, right? So we would consider an MRI with and without contrast if we were worried about intracranial hypotension, especially because there's some things we can see on there with contrast. We would consider an MRI of the cervical spine and the rest of the spine based upon mechanism of injury and exam findings, especially, for example, those reflexes if they're abnormal or the gait is especially abnormal. We would do a detailed ophthalmology exam depending on our symptoms and our detailed exam findings. Labs depending on what symptoms and exam findings and medications they might be on. A VNG depending on their vertigo component. And then we talked about again before, maybe detailed memory testing or neuropsychiatric testing depending on their cognitive symptoms and how long that's gone on. Comorbidities, as we talked about, there's many comorbidities related to headache, and those may get progressively worse depending on a head injury. So sleep issues, especially sleep apnea, needs to be evaluated, but also insomnia, restless legs, bruxism, etc. Depression, anxiety, and bipolar, as well as many other psychiatric history, including a history of abuse. Postural orthostatic tachycardia symptoms and syndrome can be worse. Musculoskeletal disorders, including hypermobility, Marfan's, EDS, obesity, and rheumatological disorders all need to be evaluated and can be comorbid to headache and traumatic brain injury. Headache is often the first symptom reported after a concussion, as we've alluded to, and is often the last symptom to resolve. Migraine is the most common with or without aura, but there can be many other headache disorders, including cervicogenic headache, cervical dystonia, tension type, trigeminal autonomic cephalgias, intracranial hypotension, and rebound or medication overuse headache. We'll get into those now. So post-concussion headache, this is our definition. According to ICD-3, so International Headache Disorders 2, the onset is less than 7 days after the head injury and is usually categorized as primary headache disorder, not by any other reason. And treatment is based upon the headache subtype and needs an exam, side effect evaluation, associated symptom, and does the patient need that toolbox treatment or just a preventive or abortive treatment for now? So normal basic pathophysiology of migraine is that normal stimuli can trigger the migraine-sensitive brain, meaning they have that genetic preload. Someone else in the family has migraine, doesn't have to be mom or dad, could be farther up. Migraine triggers can include a multitude of things: sounds, smells, light, stress, weather changes, certain foods, changes in sleep, hormones, head injury, all kinds of things. Stimuli then causes that chemical imbalance, which then triggers and activates the trigeminal vascular system. One of the things we're learning very recently is that CGRP, that calcitonin gene-related peptide, is a neurotransmitter related to pain, and one of the parts of genetic preload is that migraine brain makes too much of that pain peptide, and non-migraine brain has normal amounts of that pain peptide. Also, migraine brain doesn't make enough pain blocker or anti-CGRP. Vasodilation and neurogenic inflammation is also present, and that starts to come after that trigeminal vascular system is activated, and then peripheral and central desensitization occurs as the chain continues to go on. So migraine abortive treatments, there's a multitude. Triptans are generally considered the gold standard, but some patients can't tolerate them or cannot have them due to risk factors. So there's 9 different triptans on the market. There's DHE or ergotamines on the market. There's nonsteroidal anti-inflammatories. There's antiemetics, which sometimes can be helpful, even if nausea is not the primary symptom. There's combination medications, either with butalbital or isomethoprene. Some people can't tolerate that, and I'd be cautious about using those due to risk of rebound headache. There's the G-PANs, which are fairly new on the market. And then there's nerve blocks and trigger point injections, which again, Dr. Miner talked about. Non-pharmacological treatments, including neuromodulation, these are things such as TENS unit, there's external vagal nerve stimulation, there's a recent armband that works on gait control theory, there's light stimulation, massage, chiropractic treatment, acupuncture, biofeedback, relaxation, vestibular rehab, physical therapy, all kinds of non-pharmacological methods, as well as working on decreasing lifestyle things that can just trigger your migraine and pain. These are the chronic migraine prophylactic medication categories. So kind of, if you will, a little bit from, I don't want to say less effective, but maybe less associated symptoms and less side effects. So herbal remedies such as magnesium, coenzyme Q10, boswellia, vitamin B2, tricyclic antidepressants, beta blockers. Calcium channel blockers used to be recommended, and I want to point out that is not on the list anymore. Anti-epileptic medications, serotonin and norepinephrine reuptake inhibitors, Onubot, and then the more recent anti-calcitonin gene-related peptide injections. 3 of those are self-injection once a month, and 1 of those is a quarterly injection, a quarterly IV medication. I'm going to switch gears now and talk about cervicogenic headache. So some of this, in fact, most of it was already covered by Dr. Miner, so bear with me if you don't mind. Symptom management is usually based on imaging and symptoms. So trigger point injections, nerve blocks, physical therapy. We would consider interventional pain management, consider nonsteroidal anti-inflammatories or muscle relaxers depending on symptoms, and consider Onubot. Cervical dystonia, so again, overspasm of the cervical neck muscles. Treatment would be based upon the degree of symptoms and spasms, as well as secondary headache, secondary tremor, radicular symptoms, etc. Muscle relaxers, nonsteroidal anti-inflammatories, anti-epileptics, all to help with the secondary symptoms and pain. Physical therapy and massage, nerve blocks, trigger point injections, and then Onubot. Trigeminal autonomic cephalgia is a kind of overview of multiple different headache types. Cluster headache is under there, obviously. Cluster headache is mainly, everyone is familiar with that, and there are obviously many documented cases of cluster headache being turned on by a head injury or concussion. It's treated more with oxygen and triptans abortively and can be treated with verapamil and galcanezumab prophylactically or nerve blocks either abortively or multiple times prophylactically if needed. SUNCT or SUNA is another headache disorder underneath that. So this is a kind of headache disorder that will come on acutely. It may go away for months at a time and then come back again. And it's treated with various anti-epileptic medications, all with various results, but no specific treatment. Paroxysmal hemicrania or hemicrania continua. So paroxysmal hemicrania, again, is one-sided, and then hemicrania continua is one-sided, but is obviously continuous and doesn't go away. Responds to endomethacin, as we all know, is a super strong anti-inflammatory, but as we all know, is not a great long-term plan, so we have to come up with something else long-term once we see the patient has responded to that. Intracranial hypotension is actually the #1 misdiagnosed headache disorder, not only in headache world, but in the world. It can be very difficult to diagnose. The pain is often positional, meaning better with laying down and worse as the day goes on, worse with Valsalva, activity, sex, lifting, and exercise, but it's not always positional, which is what makes it hard, because the longer the headache goes on, the harder it is to diagnose, and the harder that the positional quality of that headache may go away. It's very similar in presentation to migraine with subtle differences, meaning that photophobia and sonophobia and nausea is there, but to a much milder degree. Patients describe a neck and scapular pain similar to a coat hanger. So basically that occipital pain, neck and scapular, but almost in a coat hanger pattern. There's some hearing component with tinnitus and muffled hearing. There's also cognitive delay that gets worse as the day progresses. But again, very difficult to diagnose. There is imaging, but imaging is not always 100% going to make your diagnosis, and it's subtle again. And unless that person who is reading your imaging knows to look for those subtle signs, and even if they do, it may or may not be present. the imaging criteria recently changed in 2019, and so again, unless your radiologist is aware of the new imaging changes and the criteria, it may not be read for those criteria. Treatment is increased caffeine and fluid, encourage rest and being in a supine position. Blood patch the first time is empiric, meaning they're not necessarily looking for a leak, and it's just done at a one-level spot. If there's some mild relief and the thought process is the diagnosis is correct, then you would repeat after a CT myelogram of the spine, hopefully looking for the leak, and the second patch is done with a larger volume and at 2 levels. Again, if there's some improvement there, you would consider dural glue, fibrin glue, if you can find the leak. Unfortunately, again, this is a difficult diagnosis, and sometimes the patients even have to go seek specialty treatment at one of the 2 CSF leak headache centers in the country, which unfortunately is not in Arizona. Again, switching gears and talking about rebound or medication overuse headache syndrome, this is surprisingly common. Patients just get desperate, as we all do, and they take too many medications of what they have available, either at home or what's been prescribed to them. And so the worst offender of this is combination therapy, such as butalbital containing products, or any medication, even over the counter, such as Excedrin. Really, they can only use those products 10 times a month. I will point out that butalbital has been off the market in Europe since 2018, and it came off the market very suddenly. So our European colleagues in European Headache Society have lobbied very heavily for us, obviously in headache world, not to prescribe it, which most headache specialists do not, but they've lobbied for us to use other products, because when it came off the market suddenly there, they had many patients, as you might imagine, having seizures, withdrawal symptoms, etc. So we really do want to move our patients toward better options. Narcotics, ideally, even if it's used for other issues, also can cause medication overuse headache. I joke with my patients that your brain doesn't know why you took it. And so again, ideally, that should be less than 10 times per month. Non-steroidal anti-inflammatories, again, ideally less than 15 days per month. Triptans or ergotamines, ideally less than 10 times per month. Also, of course, because it puts you at risk for vasospasm, stroke, etc. And then caffeine, again, remember this is a drug, and that should be limited to less than 200 milligrams per day. If patients are combining all of these things, then it should be limited to 10 times per month. And remembering that withdrawing these things may cause a temporary increase in their migraine-like symptoms or a temporary worsening of their headache syndrome. And sometimes they'll need something to patch them over during that time to help with their headache. So in summary, be sure to listen to your patient to get the correct diagnosis. Don't be afraid to reassess and ask questions, and if you're not making any progress, go back to the history and re-listen to anything. Sometimes patients forgot to tell you that in the middle of everything something changed. Maybe they bunked their head, or maybe something like that. So reassess and re-listen to your patient. Imaging can be helpful but does not always answer questions. Watch for comorbidities, side effects, and medication overuse headache disorder. Ask about how often they're using their medications, even the over-the-counters, and try to use a toolbox approach so that the patient feels empowered that they have something to take for their, whopper migraines, as I say, their nausea, their prevention medicine, etc. This is my joke. These are some of my prevention options. Obviously joking, but it does seem to help. And these are my abortive techniques. And I'm kidding, because alcohol obviously is a trigger. So any questions? After a concussion, at what point do you start to consider migraine medication in someone with a migraine phenotype but no history of migraine, and what meds are best to start with? First line, second line. So obviously I would defer to some of my concussion headache friends here and rehab specialists. I would ask them to start therapy and all of that kind of stuff. If they're not making progress, usually within about 4 to 6 weeks, then I would start medication. All of my migraine prevention medicines, even in my even in my migraine patients without a history of head injury or anything, I always think of comorbidities. You know, does that patient not sleep well? Maybe I would consider amitriptyline. Does that patient obese? Well, then I wouldn't want to use Depakote. Does that patient have a history of kidney stones? Well, then I wouldn't want to use topiramate. So I'm always thinking about what else is going on. Does that patient prefer herbal remedies, but they're going to take a little bit longer? So it depends on the patient because we're always thinking about comorbidities. What are your thoughts on proposed natural remedies such as turmeric, fish oil, and magnesium supplements? Families routinely ask me what I can do naturally. I totally recommend that. Turmeric and fish oil have not been studied by American Headache Society with double-blind placebo-controlled studies, so I do not recommend those two. However, magnesium has been studied routinely. The other ones I mentioned, so riboflavin, vitamin B2, boswellia root, has been studied by American Headache Society. Feverfew was studied as well. It was not found to be effective. And then the last one, I know the brand name and I can't think of, anyway, I'll come up with it, was also found not to be effective. So those are the ones I tend to recommend. There's a site on American Headache Society that you can pull down. It is free, that has a handout on supplements and headache, gives the articles, gives the placebo, gives what dose and all that kind of stuff. And I routinely hand that out to my patients. Can head injury trigger POTS? I have not personally, in my clinical experience, seen it trigger POTS, but I have seen it worsen POTS. That's been my experience. That's it. Okay. Okay, and we'll turn it back over to Dr. Mo.
Thank you so much. Wonderful presentation from METs. Thank you for that. Up next, we have Dr. Dusenberry, who is my pleasure to present. He is a native Tucsonian and went to U of A Medical School, and that's where we originally met when he was in his training and rotated with us over at Spark. And we're very privileged and fortunate to have him after his Pediatric Sports Medicine Fellowship to come back and join us. He's also one of our new pediatric sports medicine physicians that's joined the team. So we're very excited to have him. And he's got a wide variety of areas that his sports medicine expertise takes him into. But he is stepping up today to cover the mood and sleep disorders and concussion. And I'm very excited to watch his talk. Thanks.
All right. Nice to virtually see everybody. So as Dr. Mo mentioned, I'm going to be talking about mood and sleep disorders, so a broad topic, but we'll do our best to kind of do a nice overview of all of these things. So our objectives today are basically going to be to identify some common sleep disturbances, identify risk factors for development of mood symptoms after concussion, and then also really focusing on trying to find some appropriate strategies to try to treat both of these symptoms after concussion. So as was previously mentioned a number of times in some of the previous talks, we like to kind of think about concussions into separate categories, and the ones that I usually like to talk to patients about are thinking about a cognitive category, a physical category, a mood or emotional category, and a sleep disturbance kind of category. So obviously we've touched on some of the physical things, some of the headaches, things like that, return to learn, and now we're going to focus a little bit more in on some of these mood and sleep issues that we can see. So I kind of created this. You can see I have a lot of skills in the PowerPoint realm. These are 3 circles basically trying to create a Venn diagram of how these things can overlap and interact. So you can certainly have a concussion and not have any mood symptoms. You can have a concussion and not have any sleep symptoms. Or you could kind of fall in between that area. And really that middle area there where you're having a concussion, mood symptoms, and sleep symptoms should be much bigger, but again, my PowerPoint skills are somewhat lacking. So just imagine that center triangle, if you will, being much larger. So we'll break this up into kind of 2 categories. We'll talk about sleep, and then we'll talk about mood as well. So starting with sleep disorders. So what in general are we kind of looking at there? So you could have trouble getting to sleep. You could have trouble staying asleep. You could be sleeping a lot more than you usually do. You could be sleeping a lot less than you usually do. You could be having a lot of trouble during the day functioning because of your poor sleep at night. You could maybe be sleeping okay, but your sleep quality isn't very good, so you're not getting a lot of that REM restorative sleep. And all of these things are certainly going to lead to increased fatigue, right? So then so why do we care about sleep, right? In general, feel a lot better when you sleep, but in sports, there's actually been a fair number of studies that show the specific benefit and or detriment of sleep. So I'll kind of refer you to this review article down at the bottom there. But they kind of go back and look through a bunch of the different previously done studies, and they show that there's a decrease in endurance, decrease in sprint performance with reduced sleep. You have decrease in accuracy. They looked at a couple different sports. They had some decrease in accuracy with darts. They had decrease in accuracy with basketball. They had decrease in accuracy with tennis. They found that if you only slept about 5 hours one night, then the next day your tennis serve actually reduced its accuracy by 53%. So showing a pretty substantial change with just one night of poor sleep, right? And then there's other things. You're at an increased risk of getting an injury if you're not sleeping well. You're at an increased risk of being sick if you're not sleeping well. And then, as will be a common theme throughout my talk today, there's this interrelation between depression and sleep and mood symptoms and sleep. So the less you're sleeping, the more likely you are to have that kind of risk of depression. And then on the flip side of that, so say you're sleeping more, is that actually going to benefit your athletic performance? And yes, they did find that. So they found that by sleeping more, there was a specific study on college basketball players, actually out of Stanford, and they tried to increase their amount of sleep per night by about 1.9 hours was what it wound up averaging to, and they did that over a 5 to 7 week period. And they actually increased their free throw percentage by 9%, and they increased their three-point percentage by 9.2%. And they also had increased reaction times and sprint times as well. So definitely showing that not only is decreased sleep a detriment, but increased sleep is certainly going to be a benefit for our athletic population. So then we want to look at how frequently are we actually seeing these sleep problems in concussion. So it kind of depends on what study you're looking at. I just pulled a couple and with a wide range there, but somewhere between that 30 to 70% of patients after a concussion is going to have some form of sleep disturbance. So it's clearly a big deal, very frequent, and something that we certainly want to recognize and address when we can. So then I wanted to look a little bit more into what the interrelationship between a concussion and sleep problems are. So in a couple of these studies, they were actually looking and showing that as you have a concussion, you're more likely to have some sleep problems. So the first one was Barlow, who's done a number of really good studies on concussion and sleep, but she found that as you went further along in your concussion, you were actually more likely to have higher levels of sleep as compared to those who had already recovered from their concussion, and their sleep symptoms, if they had any to start with, had already kind of dissipated and gone away. Versus this other study by Blake, where they found that the increased rate of sleep disturbances in those who have already recovered from concussion. So even after you've had a concussion, you're still at an increased risk of having some sleep problems. So these ones tend to point more towards having that concussion leading to sleep problems. But then we can also see where maybe sleep issues could lead to worsening of concussion. So Chung and their group took a bunch of people with concussion, and they subdivided them into a poor sleep group and a good sleep group. They did this with the Pittsburgh Sleep Quality Index study. So those who scored higher on that survey, on that screening tool, I should say, wound up being in the poor sleep group. Those who scored lower wound up being in the good sleep group. And they saw that those in the poor sleep group not only had increased symptoms and increased total symptoms, not just sleep symptoms, at the 3-month level after an injury, but also initially after an injury had a lot of increased symptoms as well. And as we've already kind of heard today, the more symptoms you have, the more likely you are to have that prolonged concussion. And they even went a step further and subdivided that out and saw that the sleep group actually did have a 2-week longer time frame to recovery. So again, kind of suggesting that having these sleep issues is going to lead to a worsening concussion. Bramley, similar study in the sense that what they find at the end is that there was a 4-fold increase in recovery time for those who are having sleep disturbances in the setting of concussion. So then we also want to say, well, does poor sleep have to be potentially a risk factor for concussion itself? This was actually a study done here at U of A, and they took a bunch of athletes before they had had a concussion, did some surveys on them, tried to see how many of these athletes were having any kind of sleep symptoms, and they rated them from those with the moderate to severe insomnia actually had a 2 to 3 times higher risk of a future concussion. So suggesting that maybe there's some aspect of poor sleep in itself that's leading people to be at an increased risk of concussion as well. So basically all that boils down to which one's coming first. Are we having sleep symptoms that are causing the concussion? Are we having concussions that are causing sleep symptoms? Is it a little bit of both? And I would suggest that it's probably a little bit of both. There's some aspect of getting a concussion that could certainly make your sleep worse, or you could have some sleep issues prior to your concussion that can make your concussive symptoms worse. So either way, we want to address whatever's going on and see what we can do to try to make these patients have a decreased symptom burden, and see what we can do to help them not only with how much symptoms they're having, but see if we can reduce the length of time that they're having those symptoms as well. So the things that we can do, big one is sleep hygiene. That's number one. That's what we talk about with any and every concussion. The first time they come into the door, making sure that they're working their best to really do the non-medication steps that they can first to see if we can get these sleep symptoms improved. While that is our first one, it's also probably our hardest one to do, in the sense that sleep hygiene in general is definitely always a good thing to try to do, but it can be a little bit challenging to actually get it going. And then melatonin, a medication, but some people kind of consider it a little bit more natural, as it's a hormone that's already produced by the body. So that can kind of help us with our circadian rhythms. We'll get into that a little bit more. There's some prescription medications we can take. Then our big one is going to be some therapy, so cognitive behavioral therapy for insomnia. And then a couple new ones, blue light therapy, whether or not that's kind of more hot off the presses, so to speak, and we're trying to figure out whether or not that's going to be really a helpful thing. And then, as you've already heard before, exercise is medicine. Active rehab is going to be great. We're definitely going to want to suggest that to all of our patients, obviously sub-symptom threshold. So getting into a little bit of sleep hygiene, probably stuff most people already kind of know, but we're going to want to make sure you have a regular bedtime or regular wake time. Having that set schedule and trying to keep that schedule even on the weekends is really big to try to help reset that circadian rhythm and make sure people are sleeping appropriately. Bedroom bed, only using for sleep. We're not going to be playing with our phones, playing on a computer in there, doing other things. Cool, quiet, dark rooms, obviously important. We try to, as I said before, limit the electronics before bed. This kind of gets into that blue light a little bit as well. So if we can turn it on to night mode, or have the blue light filters on the screens, or even wearing blue light glasses, can certainly be beneficial to helping people get to sleep. Want to avoid caffeine. If you're a person that has to have caffeine, we then would say you certainly should avoid it at least prior to noon, or excuse me, afternoon. And then daily exercise, again, that exercise is medicine, going to be really beneficial to helping people get tired enough to want to sleep later. The only caveat with that would be we certainly don't want to have people exercising right before bed, because that can actually rev up your system a little bit more and make it a little bit harder to go to sleep. And then what we see frequently in people with concussions is that they get really tired and they wind up taking naps in the middle of the day. So what happens then is they get a little bit thrown off of their sleep schedule. Their circadian rhythm can get a little bit off, and because of that, they have trouble sleeping at night. So naps in general aren't necessarily bad, but if you're having trouble sleeping through the night, then we definitely want to have you avoid those naps, because that could be throwing that off. Once you're sleeping through the night, and if you're still tired, concussions, they require rest. They require that time to take that extra sleep. And if you need that extra sleep in the middle of the day and you're still sleeping at night, that's okay. But we certainly don't want those naps to be affecting your nighttime sleep as well. So melatonin, again, like we said, it's a hormone that's naturally secreted by your body, coming from the pineal gland. It certainly helps with your circadian rhythms. The thought is that it is going to first be starting to be secreted around 2 hours prior to sleep. About 5 hours later is when that's going to peak. Again, helping with that sleep onset. But there's also been some studies that show it has some neuroprotective effects and has some antioxidant properties as well. It's generally pretty well tolerated, which is why it can tend to be our first line pill that we're going to be suggesting for people. However, the American Academy of Sleep Medicine does not actually suggest it, as there's no great evidence as far as the efficacy of this medication. So it's loosely skewed towards helping, and there's certainly a lot of stories of patients that have had a great benefit with melatonin, so we feel pretty comfortable prescribing it. Specifically, more melatonin in concussion. There's been a number of randomized controlled trials. I'll just highlight a couple of them here, but showing one that shows melatonin versus placebo and showing an improvement in that sleep onset in those people that have had a concussion. In that Bramley study that we referenced before, they actually wound up taking the people who were having some significant sleep issues there, gave most of those people melatonin, and of the people that were having both sleep issues and were given melatonin, 67% actually showed improvement with their sleep. So a pretty high number, and another study that kind of lets us lean a little bit more heavily towards saying that melatonin can certainly provide some benefit. There's also a pretty interesting, unique new study where they tried to do a randomized controlled trial of melatonin versus placebo in children that had prolonged post-concussive syndrome or symptoms. And what wound up happening with that was they didn't actually show a benefit. The only thing that I would kind of caution you with taking that evidence from there is that they didn't subdivide those people who had the persistent concussion symptoms into people who had sleep symptoms and people who didn't have sleep symptoms. So they just lumped them all together, which is probably part of why they didn't show any benefit. So it does kind of talk more to that antioxidant neuroprotective aspect, and perhaps that isn't enough to provide a benefit in post-concussive symptoms, but this one doesn't really cross out the fact that melatonin could still be beneficial in people with sleep issues. Diving a little bit further into some of the other medications for sleep, trazodone is probably one of our first go-to ones. It's an antidepressant, but at lower doses can be used for sleep. The only issue with this is sometimes people will fall asleep with this, but then not be having quite the same restorative sleep, so maybe not getting as much of that REM sleep as we would hope for them to have. Ambien, another pretty common sleep aid that people use. That's a non-benzo, but also works on the GABA receptors the same way the benzos do. The idea of that, though, is that it should be a little bit less habit-forming, and while it is less habit-forming and less sedating than the benzos, it certainly still has its risk profile. So we don't wind up prescribing a whole lot of that unless these are people who have really had prolonged issues with sleep, and all of our other options aren't working quite as well. Amitriptyline, as Dr. Tees had just mentioned, it's not specifically for sleep. We use that much more frequently for migraines and headaches, but it does have the benefit of having the side effect profile of making you a little bit drowsy, and can certainly then help with sleep if you're not only having the migraine type headaches with your concussion, but also having sleep issues. And then the benzos and the Benadryl, we really don't do much of that or recommend those, mostly for safety profiles and side effect profiles. So the big one for sleep that we would really, if we could, get everybody into this is therapy. So cognitive behavioral therapy for insomnia has lots of studies that are showing its benefit, more so in the adults than the pediatrics, but there are some in pediatrics as well that show benefit. I'll highlight this one down here that's CBTI with, RCT of CBTI versus treatment as usual in adolescents with concussions and prolonged symptoms, and actually did show that improvement. So it's really helpful for those patients. And then this last kind of new frontier therapy is blue light therapy. And so the idea of that is kind of the same way we say you shouldn't be using blue light when you're going to sleep. The idea is that you're kind of simulating being outdoors, being somewhere where you're seeing this blue sky that's then reflecting back into your retina, that goes back down into your pineal gland, and then stops the secretion of melatonin. So if you're not secreting your melatonin, then you're not going to get started with your normal circadian rhythm of feeling tired and getting to sleep. So they kind of flipped that on its head and said, well, if it's not good to give blue light when you're sleeping, maybe it would be beneficial to give blue light when you're waking up and resetting that circadian rhythm in that way. So they did a trial of amber light versus blue light. They gave it to patients for 30 minutes in the morning, and after a number of weeks, they found some pretty impressive benefits. While it didn't increase the overall duration of sleep, it did move forward their sleep time, so their sleep onset moved forward. They had reduced daytime sleepiness. They had improved executive functioning. And even on the MRIs with the DTI, they showed some benefit as well there. So definitely, it's a new thought, but it's certainly something that we could be implementing, and it's not hard, especially in places like Tucson where we have sunny days and blue skies most of the year. If we go outside in the morning and just ask our patients to try to get out in the morning, and they could even be doing their rehab exercises at that point, going for a light walk, doing that exercise as medicine, but also getting some blue light at the same time, kind of killing two birds with one stone and working on all of their symptoms at once. So moving forward into our mood disorders. So again, just first want to highlight what kind of mood symptoms can frequently be seen in concussion. And again, it varies pretty widely. Some people could have none. Some people could be facing with a lot of anxiety and depression. Irritability is certainly very common. Attention issues is a frequent thing, whether they had that prior or it's starting afterwards. Depending on how you got your concussion, PTSD can certainly play a role. And in our younger patients, we certainly see a lot more behavioral disorders, some kind of personality changes when they're having kind of a hard time describing how they're feeling and what they're going through. Some of that winds up turning into just behavioral issues. So how often do we see these mood symptoms in concussion? So again, just pulled a couple studies for you here that show kind of the variability of how often we see it, but generally speaking, somewhere in that 20 to 50% range. So it's definitely not uncommon for us to see kids or adults with mood symptoms after concussion. So then again, we kind of want to look at how this interplay between concussion and mood symptoms go. Are the concussion bringing out mood symptoms? Are mood symptoms causing a worsening of concussion? So these studies were basically showing that when you have mood symptoms, you have a longer duration of your concussion. So the first one was showing that those with depressive symptoms had a higher post-concussion symptom score. And again, as we talked about before, higher post-concussion symptom scores can certainly portend to a longer prolonged concussion symptom as well. And then we also see that pre-concussion depression or anxiety are markers for prolonged concussion themselves. So even before you have this concussion, if you have depression, you have a higher risk of having that prolonged nature of your concussion. So then we wanted to look a little bit into our concussion issues specifically leading to mood issues. So there's this nice study by Kerr. It's a bunch of NFL players, all retired. None had depression at the time. They surveyed them over a 9-year period. So surveyed them once, and I think it was about 2001, and the next time was 2010, and basically tried to ask how many concussions they had in 2001, and then when they came back in 2010, tried to see how many of these people were then diagnosed with depression. And what they found was those with a history of concussion had a higher risk of being diagnosed with depression 9 years later, And even more interestingly, the more concussions you had, the higher the risk was that you would have depression. So again, this kind of leads us to the thought that maybe concussion itself has some aspect in putting somebody at an increased risk of having depression, not only during that concussion, but later as well. And then this other study was based off of Chrisman's work, and they again showed a 3.3 times greater risk of having depression in adolescents specifically who had had a history of concussion as well. So then we want to talk a little bit about anxiety. This is definitely a common thing we see in our patients with concussion, and kind of as Becky had mentioned earlier, these kids, especially in the adolescent group, their whole life revolves around their specific sport, and a lot of these kids wind up that's really their identity. And so when you take away that because of an injury or because of something else, specifically with concussion and prolonged concussion, it can really affect them from an emotional standpoint, and anxiety is a big one that we see with that. So they may be worried about losing their position on the team. They may be worried if they're potentially going to go to a college level and get rid of and lose a scholarship, or moving from the college level on to the professional ranks. And then they can their relationship with their teammates can change, and their ability to kind of interact with their teammates really can take a big hit if they're not able to get out there on the court or on the field and have that same dynamics that they're used to having. And this same thing can kind of result in adults. It's a little bit different worries as you grow up and have a family and have other things to take care of, but you can be certainly have some great anxiety about your income, your ability to provide for your family. And then obviously everybody's at a higher level of anxiety right now with a pandemic going around, and so everything's just super heightened at this point. So we definitely want to be very aware of that and kind of talking with our patients about that as well. Concussion and ADHD, there's actually a really wide array of literature on this one. Iverson was a study that Dr. Moe had mentioned earlier, and he's a researcher out in Maine who has some great studies that actually have really large population samples. So he gets to about an N of 30,000 or more. His original studies back in 2016 suggested that there was a higher risk of concussion in those with ADHD. They then did a systematic review a year later and said, maybe it's not that substantially greater, it's not as much as we thought. Then again, in most recent study in 2020, again with, I believe his N was about 36,000 for this one. And what they're doing in a lot of his studies is they use impact testing, which we had seen before, and they do that as a baseline before these kids start playing. And then they go back and look for those who had a history of ADHD or learning disability and see whether or not they had a higher incidence of concussion. And what they wound up finding was that those with those previous conditions do wind up having a higher incidence of concussion. So again, suggesting that there is a relationship there. And then further down, this next study actually is showing more that a predating ADHD prior to your concussion also has a higher risk of you having a concussion. So 50% of those adolescents had concussion if they had predating ADHD. And again, they also show that you have a higher symptom burden with ADHD as well. So again, this goes back to showing that there is this interplay and this interrelationship between concussion and mood, whether or not concussion is causing mood or mood is causing concussion. It certainly seems to be a little bit of both with most of the data that we've seen. So again, whether or not one is causing the other, we certainly want to be able to treat them. So what are some of the ways that we can treat? One of the big ones that we kind of gloss by sometimes is reassurance, education, support, and then mindfulness and relaxation. So we'll touch base on those a little bit too. But then again, our big one is going to be that therapy. So that cognitive behavioral therapy. If all else fails, or if they're so bad, we may wind up starting some medications as well. And as always, active rehab, exercise is medicine. You've heard me say this ad nauseum already, but it's always going to be beneficial as long as we're doing that sub-symptom threshold. So these studies, I wound up looking at a systematic review and kind of looking a little bit further into this. Again, some of these patients, they just don't understand that having a concussion can lead to some of these mood symptoms. So they don't put 2 and 2 together and say, well, I've been feeling a lot more irritable. I've been feeling a lot more depressed recently. Yeah, I had that concussion, but I think this might be something else. So giving them that reassurance and that education that it's pretty common to have some of these things happen after a concussion not only lets them know that they are quote unquote normal and that this isn't something new that's going on for them. There's a reason why these symptoms are happening, but it also lets them kind of breathe a little bit and lets them understand that, okay, maybe, as my concussion gets better, so will these symptoms. So they wound up looking at 10 randomized studies for the reassurance and education, mixed results, but again, they skewed towards positive, and there's really no negative aspects of giving them reassurance and education. So I think it's something that I definitely suggest. And then same with relaxation and mindfulness, a little less randomized studies for that. They only had 2. One suggested that it was beneficial, one showed no benefit, but again, neither of the studies showed a negative aspect of doing this relaxation and mindfulness techniques. So I think it can only benefit, if anything, so it's certainly worth a try. Of course, our big one for people who are really having a lot of trouble is going to be that CBT. There's been a number of randomized control studies for this. All of them are showing benefit. These are all specifically for mood issues in the setting of having a concussion. Again, they all show that the intensity, duration, overall improvement of your anxiety and depression by doing some of these therapy techniques. Getting into a little bit of the medication for mood symptoms, certainly our first lines are going to be the SSRIs. If those aren't working, SNRIs can be tried as well. There's a meta-analysis from 2018 that didn't actually show any benefit for these versus placebo. I would caution you with the results of that, though, because they included a study that had questionable mild TBI patients. Basically, they were really more moderate to severe TBI patients. They rated them, the only way they got started in this study was whether or not they had findings on their CT initially after injury and whether or not they were admitted to the hospital, which are certainly things that we don't frequently see in our concussion patients. So if you removed that study from that 2018 meta-analysis, then there was a significant benefit for the SSRIs or SNRIs versus placebo. And again, this study below is kind of more of a review study, reviewing that meta-analysis, but then also suggesting that even if there wasn't a benefit for the SSRI versus the placebo, both groups did benefit and get better as time went on. So whether or not the SSRI is specifically working in the way you think it is, or whether it's a placebo effect, it may actually be worth giving the SSRI as a placebo, in the sense that if it's still going to improve these patients' mood symptoms, and knowing that a lot of these medications that we start, the goal isn't to be on these for a long period of time. The goal is to be on these until your concussion symptoms improve and we can wean you off of them. So lastly, I just want to touch on, and we've kind of touched on it a little bit before, but this kind of interplay between sleep and mood as well. So just a couple studies that are showing how frequently you'll see mood symptoms with sleep symptoms and how frequently you'll see sleep symptoms with mood symptoms. And then again, that last study showing that the levels of anxiety and depression are they're certainly correlating, and you're also going to see them really frequently, they're correlating with your sleep. Your anxiety and your sleep are correlating, and they're frequent in your TBI patients. So again, just showing that there's this kind of interplay between these two. So take-home points. Definitely want you guys to be aware that there is this bidirectional relationships between all of these things, right? So concussions can lead to poor sleep can lead to prolongation of concussions can lead to worsening of mood can lead to prolongation of concussion, and then there's also this kind of question of, do mood and sleep themselves prior to concussions, are they a risk factor for concussions in the future as well? And then obviously the interplay between mood and sleep. And then the big thing is just recognizing these things, right? If we can't treat something if we don't recognize it. So as soon as we're seeing that these are major issues that our patients are having, we want to make sure that we're giving them some tools and some ways that they can try to get around these things. Again, concussions aren't forever. Eventually people are going to get better from them, but the longer they last, the longer people are struggling with these, the worse some of these sleep and mood symptoms can get. So we just want to make sure that we address them early. A list of some of my references so that you can go back and look at any of those if you'd like to. And then I'm happy to take any questions that anybody has. All right. After concussion, at what point do you intervene if there is sleep issues, and in what ways? Also, what meds? So again, like I was just saying, I think the earlier the better. So from day one, when they come to see us, we're always going to say, you know, what's going on with your mood, what's going on with your sleep. And if they're having any issues from that point, we're going to start right away. I generally, like I tried to mention before, was say that I want to try those non-medication ways first. So I want to try to make sure that we're maximizing our sleep hygiene. We're doing as good as we can on that. If they want to try some melatonin because they're having a little bit of trouble getting to sleep, I'm certainly okay with them doing that from the get-go. As far as additional meds after that, I want to wait a little bit and give them time for one to see if that sleep hygiene or that melatonin is going to help. But then there also should be doing that active rehab at the same time, and that can certainly help with sleep as well. But if that hasn't helped in the first week, 2 weeks, 3 weeks, then we can start talking about, do we need to do some other meds? Or if it's so severe early on, we may be talking about doing some medications earlier than that too. Next question, if you start an athlete on a medication like an SSRI for mood and they recover otherwise, do you let them return to sport? That is a really good question. That's something that we struggle with, because that's, you know, in a headache situation, we can easily say, you know, if you have to take a medication to get rid of your headache, then you shouldn't be ready to go back to sport. If you have a pre-existing depression that the concussion is making worse, that's a situation where I would lean more towards, well, maybe we weren't treating what we needed to treat before, and maybe we can let them kind of start working on getting back to sport if every other symptom has gone away. If they hadn't had any pre-existing depression or mood symptoms and all of this is brought on by the concussion, I would have a hard time saying that they should go back to sport because they are improved while we're still on the SSRI. I would probably try them off of the SSRI first and see if they could continue to show that their mood symptoms had improved after that. But I don't think there's a great answer for that question. There's no great scientific answer for that at this point. Next question, do you find that patients are able to self-identify their symptoms, or are their family peers reporting changes and bringing it to their attention? A little bit of both. It's dependent, one, on their age. So younger patients may have a harder time kind of really verbalizing what they're feeling in their head. Older patients may be able to say, yeah, I'm just angry all the time. I wasn't having that before, and now I'm just irritable with every little thing. But it winds up being a little bit of both. There's definitely times where I ask the patient, you know, how are you doing from a mood standpoint? And they say, oh, I'm doing fine, no problem. And mom in the background or dad in the background's raising their hand like, can I interject here? And they've got a list of 5 things that the kid is doing differently than they were before. So it goes both ways. So I think asking both the parent and the patient, or if it's an older patient, asking the patient and whether that be a different family member, what kind of symptoms are happening, I think is definitely a good thing. All right, I think that's all the questions. So thanks for having me.
All right, thank you so much, Dr. Dusenberry. That was fantastic. I know those are 2 topics, that sleep and mood, that come up again and again. High rates, as Dr. Dusenberry mentioned, with so many of our concussions, especially with our prolonged symptoms. So we didn't have really the the privilege of having those last year, and it was great to be able to add those to the symposium this year. So thank you so much for that. Okay, I'm going to pick up on this last session, which, like I mentioned, is a bit of a curveball from the concussion because it is on COVID return to sport guidelines. There was a lot of, obviously this is important right now, and there's been a lot of requests for something on this, and luckily we've had a lot of recent great conferences covering this. My goal in these 30 minutes is not to really be able to do much more than what the time allows. But I do want to focus in on return to sport guidelines and at least bring out some of the recent criteria that has come out, and that's of course a very evolving thing. So what I present to you today, frankly, may be different in a couple of days based on the research that we're seeing come out, pretty regularly on this. So I'm going to just quickly do some background on the disease, but of course the goal of this talk is not to get into the pathophys of COVID, but rather focus in on return to sport and return to exercise guidelines, because that's, whether you want to talk about Tucson or Phoenix or across the country, that's kind of what we're up against right now, depending of course on regional rates and that sort of thing. We are trying to get the kids back out to start to do some exercise, at least in a safe way, and that's going to be the focus today. So really quickly, the disease, I think most of you guys are familiar. It's a multi-systemic really disease that has a lot of different manifestations with respect to symptoms. We've seen in some of the research that fever and respiratory symptoms obviously seem to be up there with respect to what we see with COVID-specific symptoms. However, GI, rash, these are all other symptoms that we see as well. So it makes it a little bit harder clinically to be able to pinpoint. Now that's where testing comes into play. The other big point with COVID is the sequelae. So there is a lot of concern that we've seen this at least in the hospitalized patients, that cardiac, pulmonary, neurologic sequelae are at pretty significant rates. So we'll talk about that a little bit today and how it pertains to an athlete trying to go back to sport, because obviously particularly the cardiac piece or the cardiopulmonary piece becomes pretty important. Morbidity, mortality, basically you can see on the bottom right there's a list. And more or less, it's important to understand that this really affects, by and far, the higher risk groups. So that's going to be older age, comorbidities is the big thing. And when we talk about comorbidities, the big ones right now, as you can see listed on the CDC website there, are going to be immunodeficiencies, metabolic disease, cardiopulmonary disease, and obesity. And so luckily we don't have a ton of that in our young athletes, and they're also not in the high-risk age group either. So because of that, it's kind of a different ballgame in that group. And then the high infectivity of COVID. So this has definitely been something that's, we haven't dealt with in a long time. Maybe the closest thing was Ebola, but basically we're dealing with something that we know has a very high infectivity rate, and it's some of the recent research is suggesting it's more direct contact and aerosolized as opposed to sort of surfaces. Another critical point about COVID is that during the asymptomatic phase or even the mildly symptomatic phase, that these folks are still potentially very highly high vectors of infection. So we need to be careful for those few days as well when they don't present with any symptoms. And we know some people will never present with symptoms, but that doesn't mean they still can't spread the disease. And finally, that a lot of the research right now is suggesting that the highest virulent vectors tend to be the adolescent and the adult age groups as opposed to the younger kids under 10. And more data is coming out on that. Obviously, the disease can be spread by anyone. So the general concepts with COVID really have been risk mitigation, right? So we are trying to socially distant, use PPE, screening, testing, contact tracing, immediate recognition of outbreaks and reacting to them. monitoring community transmission rates and figuring out, are we in the red zone, the yellow zone, or the green zone with respect to how much disease is out in the community, and that obviously is going to dictate how careful we need to be with risk mitigation. Do we need to stay in our homes and not go anywhere, shelter in place, or can we be doing things with certain precautions in place? And then the resources that are available to us. Hospital capacity and hospital resources kind of trump everything. If your hospitals are full, you're in trouble, and we have to be really careful. So these are some of the things we'll talk about as we get into risk mitigation and how that dictates as benchmarks for how we can move forward with respect to what we're doing with return to sport. And so ultimately, returning to organized activities in sport does require sport-specific planning and mitigation. So we have to start to look at that environment, whether it's conditioning outdoors or weightlifting, or whether it's an outdoor sport or an indoor sport like volleyball, and sort of where that falls with respect to risk mitigation and at what point are we ready to do those things. So there's three major aspects to the guidelines that are out there. I like to break them up into prevention, screening, and management. And I kind of see this as a upside down pyramid. Obviously, when you talk about prevention, it involves everybody. Every athlete that you have out there and everything they do, prevention's a part of that, right? As you get all the way down to management, those are going to specifically involve the folks that end up with positive tests, and then how do we deal with that with respect to their care, but also not exposing others. So the prevention guidelines, we have a number of different institutions that have put out some great guidelines with respect to this, and the focus is on precautions, which include distancing, masking, cleaning, etc. Phasing, so we are gradually trying to tread lightly moving into activity, and phasing is how we do that, and I'll describe that. And then the sort of the progression of phasing, right? So at what point can we move forward, and there's community benchmarks that are going to drive that. And at what point can we even initiate? So 4 key precautions. These precautions include, when we're talking about prevention, cleaning, rigorous hygiene program, hand washing, cough and sneeze etiquette, and masking with the non-vigorous exercise and during practice downtime. You all can probably think about scenarios where there's an hour training session or whatever where the kids are conditioning, and how much downtime there is from when they arrive to when they leave, and when the coach is talking to them, and so on and so forth. And so our goal is to make sure everyone shows up with a mask and has the mask on for any part or all of that they can. Obviously, as we get into vigorous exercise, there's risk of wearing the mask with respect to heat illness and respiratory illness and so on and so forth. So at that point, a lot of the athletes will be able to drop their mask, maintaining distancing, so on and so forth. So the AIA and the NFSH, National Federation of High School, both have some great guideline papers that, again, we'll make available to you guys on the website, among some of the others. So this is a lot of where the information is coming from. And in general, when we break down these guidelines, this is sort of how they read. So it's really important to start with functional team units. These are little pods of 5 to 10 people or athletes. And the idea is that you maintain consistency through that pod, so that if anything is to occur, meaning one of those kids ends up becoming a positive screen where they're very symptomatic, or even a positive COVID case, now you've got 5 to 10 others that are exposed and not 100 others. So that's kind of the key there. The drills, maintaining spacing, just the same 6-foot rule as far as that's concerned. Obviously, if you're within the same pod, there will come a time as you move forward in your phasing that there may be closer contact. But in the first couple of phases, the whole idea is no contact. So outdoor versus indoor makes a big difference. And so, again, with the early phases, we try to keep things outdoor because of that aerosolized risk that can occur, especially with poorly ventilated indoor places, but indoor in general, regardless of how good the ventilation is going to deem a higher risk for spread of disease as opposed to outdoor. So we definitely start with outdoor activities with phase 1. Also other kind of common sense things, right? Water bottles and whistles and spitting and yelling and mouth guards, so making sure that some of those things that are vectors for spreading disease are just eliminated, and other things like water bottle, because you need water, or you have your own, so there's no risk of sharing water bottles, so on and so forth. So pull-up masks, or whatever kind of mask these guys can wear, again, during that downtime becomes critical. And it's very important that the coaches are also abiding by all these rules. Remember, they're the example for these athletes, number one. And number two, they're just as much of a risk to the others, and there's as much of a risk to them, so they need to also be masked. And in their case, they should be able to be masked the whole time because they're not really doing anything vigorous usually. Face shields is another thing that we're starting to see now with some of the sports progressing, NFL, et cetera, to phase 3. And it is probably more of a phase 3 thing because it sort of helps in certain sports where it's possible with some of that spread of close contact. So we'll probably see more of those as well as we move forward. Specifically on the functional team units. So the idea here again is to minimize the exposure impact. So if you have a positive COVID in your pod, now you've affected 5 to 10 people that then have to be pulled and go get tested and so on and so forth. And hopefully if you're maintaining good precautions, those other 5 to 10 people will end up being negative. And that's sort of the idea there. Instead of now you've got 100 kids that were potentially exposed and you got to deal with all of them and you overwhelm the healthcare system as well. So it is definitely a critical part of defining our phases. As we move forward, obviously the functional team units become harder because you're bringing more and more of the athletes together, especially for competition, which is more of a phase 3. And again, and I made this point already, but obviously the goal of the pods is to maintain the same people and not mix with others. So if you've got coaches that are switching off, I'm going to be with this pod today, I'm going to be with that pod tomorrow, or certainly athletes that are doing that, it defeats the purpose. So the idea is to maintain the same folks in the pod and have them progress together. So here's the phases. So the quick summary of the phases, the details are all in those documents that I shared with you from AIA and National Federation of High School. But basically phase 1, the idea is small units. So they're going to be under 10. The pods will have under 10 athletes. And it's a conditioning focused phase. Strengthening, conditioning, an opportunity to work on injury prevention. These kids have been sedentary for a long time. So COVID does give us those opportunities, and so we want to take advantage of that. They don't need to be competing or next to each other to do these things, but they can still be in a team environment, which can be very valuable for them and their behavioral health and so on and so forth. We definitely want to maintain spacing. There's no contact whatsoever. Like I said, masked for most of it, except for the vigorous exercise. And some athletes may, also choose to stay masked when they're doing vigorous exercise, as long as they know their limits. That can be fine. And this is all outdoors. And low-risk sports can start to even practice, but that's limited to sports like golf, cross country. They essentially fall into the phase 1 requirements already, so they can basically be doing their practices. Whereas obviously a sport like basketball and football, they can't do that. Phase 2, you now are up to about 50 on your units, so 40 to 50. If you're going indoors, it still needs to remain under 10 per unit. This is more of a drill-based phase. So at this point, we can start to drill the athletes on sport-specific drills, but they still are maintaining all the other precautions. They're maintaining spacing. There's absolutely no contact, trying to stay masked as much as possible. And at this point, the low-risk sports can actually compete. So if you think about how golf or cross country look when there's a competition, yes, they have to still take certain precautions, but basically they're able to initiate competition. So a number of the districts right now are sort of sitting between phase 1 and phase 2. So, as a community with our young athletes, this is kind of where we're at right now. And so, hoping that we can, again, tread lightly and move forward without having outbreaks and having to go backwards. Phase 3, this is really, I haven't seen this yet other than at the pro levels, but basically this is contact practice at this point, indoor or outdoor. Still trying to do masking and spacing as much as possible. So, and then phase 4 goes with phase 3. Phase 4 is basically a continuation of phase 3 into competition. So, And again, we're trying to maintain all the precautions we can. So if you've watched some of the basketball games, NBA, football games, right, there's obviously a number of precautions. There's no fans. When they're on the sidelines, they're spread out. They've got masks on. Those are all things that you can maintain, despite the fact that when you get on the court or get on the field, pretty much competition is what it was. So. Benchmarks for progression. So this has been, sort of a big evolving question the last month or so, but this is kind of where we're at. These guidelines here are from the AIA, and these thresholds, these benchmark thresholds that I'm sharing with you over on the right here, are from the Arizona Department of Health. So it certainly is possible community-specific benchmarks might look a little different. For example, Pima County versus Arizona Department of Health. But this is currently where we are with this data through the AIA, which is green for no or minimal community spread, yellow for moderate community spread, and red for high community spread. And if you look at the specific criteria that fit for each one of those, you can see them over on the right. So it's dependent on the number of cases per 100,000, your percent positivity, and also your hospital capacity. Those are the big three that are highlighted here. There's obviously other criteria that exist. And the idea is that if we're in a high community spread, well, we're basically not going to be doing any organized activity, or may do some completely spaced phase 1 stuff, just to get the kids an opportunity to exercise. If we're able to get to more of this moderate community, this yellow phase, we may be able to move from phase 1 to phase 2, and really looking to be more in the green to be able to move into basically contact, which would be phase 3 and phase 4, or progressing phase 2 into phase 3 and phase 4. So this is from the Arizona Department of Health. This is their dashboard. If you haven't seen this, it's really easy. Just Google it, and you can click on the data dashboard, and you have all these criteria right in front of you, day by day, and you can click on any one of them, or you can just do a summary. Here's 9 of the big criteria that we look at, everything from percent positivity to cases per 100,000. This is from about a week ago, so don't worry about the numbers here, but I just wanted to give you an example. And then you can click on any specific thing like cases per day that we're seeing, and you can see trends. And as you can see here, this has generally been our trend going in the right direction over in Pima County for the last month or so, which is a great thing. Other return to play concerns. So when we're talking about COVID return to play, right alongside that, there needs to be a consideration for heat. And hopefully we're getting out of that now here in Arizona, but that's still definitely on the table. And then obviously overuse and deconditioning injuries. A lot of these athletes have not done anything for 6 months or whatever it's been, and they are in need of a gradual progression. And in some ways, COVID phasing is great because it allows that opportunity for these athletes to go through that. Remember, the primary goal is still infection control from the COVID perspective, but it's kind of the 2 or 3 birds with one stone type of situation here. So, and we want to take advantage of that. So, so what does screening look like? So when these athletes come out, whether they're doing phase 1 or 2 or whatever, it's important that every day they're being screened before they get into a situation with others. And the big questions are, symptoms and exposures, right? Have you been exposed to someone with COVID in the last 14 days, and have you had any of these symptoms? And the symptoms over on the right are just one example from the National Federation of High School paper that has a list of symptoms. There's a lot out there. And the bottom line is different institutions are using different thresholds for what they see as a positive screen, right? And ultimately a positive screen is someone who has enough symptoms to be clinically suspicious to be removed and be tested and evaluated and tested. So some folks say, one major criteria such as fever or respiratory symptoms, certainly those are pretty concerning, clinically suspicious. And others, say 1 major or 2 minor, because a runny nose might be considered just a simple thing. So if you have 2 minor symptoms like that, then you would be considered a positive screen. Regardless of how clinically suspicious it is for COVID and whether that testing and evaluation needs to be made. So let's say somebody just with a runny nose for a day, and I usually have allergies and I think that's all this is. Regardless, any symptoms shown, stay home. There's no reason to come out to conditioning that day and risk that. So you stay home, and if indeed it's no big deal, it should resolve, and you can come back when everything looks good. If it doesn't, then you may need to go see your primary and get that figured out. Yes, it's allergies. No, it's not. so on and so forth. So anyone who does have a positive screen is clinically suspicious, would need clearance or 14-day isolation. So the clearance comes from either a presumed positive 14-day isolation or getting negative testing. And remember, there's about a 20 to 30% false positive with the RNA PCR. So what that means is we generally either got to go with the 14 days or 2 negative tests that are at least 48 to 72 hours apart. And the reason for that time frame is if they're early in disease, remember, the positive test doesn't show up a lot of times for the first 72 hours. So it's important to have those two separated by about that time frame. Our testing capacity is getting better and better. This was a big concern of mine even a month ago, but as it stands now, anyone that really needs to get tested should be able to get tested the same day. And we have a number of resources, free, not free. You can go usually see your primary that can do it. So if you're in a situation where you're saying, yeah, I can get tested, but in a week and get my results in 2 more weeks, that shouldn't be the case anymore. So it's very important you talk to your athletic trainers or whoever and utilize the resources that we have so you can get tested immediately and get your results as quickly as possible. And we are still, our gold standard at this point is a nasal PCR. And the turnaround should be the goal is about 24 hours. Sometimes it's a little longer. And the saliva test, the ASU saliva test is also another very good one that's shown very similar sensitivity to the nasal PCR. And you don't have to have something shoved down your nasopharynx. So, and I know they have several free saliva test stations throughout Tucson, and I'll share with you where you can find those. Antibody testing and some of the other point-of-care tests right now, they're still not really that reliable. So it's really the first 2 probably that are going to be your best options. Obviously, that's quickly evolving, and that may change even in another week. Pima County Health Department, their website will have testing centers, including free ones. This one right here, the Ellie Town Center, is one of the ones that does the saliva testing. I think 3 times a week they're there for several hours. So I know folks that just preventatively, just because it's free, they'll go 3 times a week and actually get tested because they live with high-risk people, and others that have that avenue for when there's concern with symptoms. So, what about positive screen exposures? So I show up and I'm, have some symptoms, and I get pulled and I need to be evaluated, but we don't know the results yet. So what about the people that have been exposed? So the idea here is that if you look at the CDC definition, an exposure would be someone who has been within 6 feet for a total of 15 minutes. It doesn't need to be continuous. And mask or no mask. So if Johnny, had a total of 15 minutes near me, even with a mask on, then that would be an exposure. Certainly, if there's any close contact, I sneeze on Johnny, cough on, say, all it takes is, just that to also become an exposure. So from that perspective, typically, if we take care of our precautions the right way, then really it's a phase 3 concern, right? Because we don't have close contact till phase 3, and if we're spacing and masking and doing those things, then someone shouldn't be within 6 feet of someone for 15 minutes. And so that would help a lot. Now, I think that the big thing there is, diving into if there was somebody that may have had some close contact, in which case they may need to also be evaluated, potentially tested. And this is obviously assuming they're asymptomatic. If they have symptoms, then they go down that same pathway. So. Contact tracing. So Department of Health Resources is building with respect to funding and resources and able to do much more than they could 2 months ago. So I think the important thing is getting them involved, and more or less the high-risk contacts will be quarantined for 14 days versus negative testing. And the same rules, right? So within 6 feet for greater than 15 minutes with or without mask. So an example of that would be if we're in phase 3, a basketball team, right? They're going to be, regardless of the time frame, the contact that they have because it's close or family members, so on and so forth. So surveillance testing is something really for the higher level teams that is currently occurring. This is where basically, regardless, weekly they're testing everybody. to make sure that they're basically screening for any positive COVIDs. We do some work with FC Tucson, and I know that that's their protocol. Every week they test everyone to make sure that they don't have any positives and don't need to basically respond to that in any way. This is, again, generally a phase 3 thing. So these pro teams are all practicing and competing. They're in phase 3 and 4 essentially. So surveillance testing becomes a great resource for them. You kind of need optimal testing resources, a closed bubble system, and that's why we're seeing it more at these higher level institutions like NCAA and the pros. So what about a positive case? So a positive COVID case, there's 2 main components. Number one, the obvious one, which is isolation. So 14 days minimum isolation. And I say minimum because if they're still symptomatic at 14 days, then they still need to stay isolated. So there has to also be 72 hours fever-free. It also needs to be 10 days since the onset of symptoms. And so if you think about an asymptomatic positive COVID, so let's say I had the disease and my family member needed to get tested who's asymptomatic and they're positive too, then it is a 14 days, despite the fact that they have no symptoms, it'll still be 14 days minimum. So, and then we get into exercise clearance. So after that period, so those 14 days, there's no exercise. So there'll be a minimum of 14 days of no exercise. And assuming they have been asymptomatic for 7 of those 14 days, they can start what's called the monitored gradual return to play protocol, right? So at a minimum, these guys are looking at, and that's a 7-day process. I'll show you what it looks like. And at a minimum, they're looking at 21 days. And that's for an asymptomatic patient, essentially, or someone with very little symptoms. So. What are the cardiac concerns? So there's been a number of studies looking at hospitalized patients. So these are generally adults that have comorbidities, and we've seen 20 to 30% myocarditis rates in those groups. Okay, we don't know about the mildly symptomatic or asymptomatic patients, especially in pediatrics. We do know that if you look at that same hospitalized group, that high-risk group, for flu, for example, it's only 1%. Myocarditis rate versus 20 to 30 in corona. So when you think about it that way, we know that this virus does tend to be a little bit more aggressive with respect to cardiac sequelae. So there's definitely research coming out right now to look at, in fact, there was a recent study, a Big Ten study looking at mildly symptomatic or asymptomatic athletes and what their rate of myocarditis was. They all got cardiac MRIs. The results are still inconclusive, so I didn't want to present on that. But basically, we don't really have the answers to the young asymptomatic, mildly symptomatic athletes and patients. So the guidelines as they stand now are based on the fact that there's an assumption that those rates are not going to be like that in the healthy, young, mildly asymptomatic patients. So, and in a nutshell, the way it works is if you're asymptomatic or mildly symptomatic, the gradual 7-day progression, maybe with consideration of an EKG, and that's case by case, versus those with moderate disease, those that get hospitalized, and 3 days of fever or 10 days of symptoms or longer are 2 factors that you can throw into moderate disease. Those folks should get a full cardiac workup by a cardiologist, or certainly case by case if you have reason to believe there's a problem, or when they're going through their gradual 7 days, they start having some symptoms that are concerning for cardiac. So. Here's the guidelines. This is the National Federation of High School Guidelines, more or less saying the same thing, asymptomatic or mild disease. The critical points are going to be the 14 days no exercise, and then once they're asymptomatic for 3 days, starting a 7-day return to play protocol. If, again, they fall into the moderate or the hospitalized groups, then they're going to get a full cardiac workup before anything happens with exercise. I've got a little hiccup here. My slides aren't moving forward. Just waiting for that. But and so this is from AIA and PCH, more or less saying the same thing. So I won't go over the details. All of these we can share with you. But again, asymptomatic mild disease versus moderate or hospitalized, those are the key points. And here is the study that came from the Academy of Cardiology, Phelan study, basically more or less saying the same thing, a little bit more conservative in this algorithm, where they're basically saying even mild disease or mild symptoms that maybe a cardiac workup is necessary. I think we're going to learn a lot more about this as we move forward, so this certainly may change. But as it is right now, those that essentially have asymptomatic or mild disease and no other red flags need to progress through this return to play. You can see the first 2 days are essentially really light, and then there's a progression after that, and then the last couple of days are higher intensity before they get the clearance, and that adds up to about 7 days there. They're monitored for any kind of cardiac symptoms throughout that, and obviously if there's any positives, then they would be referred to cardiology. Here's another example of I like this schematic. I know a lot of folks are using this return to play schematic. Some of the details are slightly different, but the concepts are ultimately the same. There needs to be a gradual return to play with monitoring of symptoms. So what about a remote case? So somebody that had COVID in February and tells you, yeah, I had disease, you know, I isolated, did all that, but I'm ready to play now. And I think the important thing with this is that you ask the appropriate questions to make sure that there was no moderate or severe disease. Were they hospitalized? How long was their fever? So on and so forth. That they have negative cardiac symptoms currently. Who cleared them? And if not, then they probably need to be seen for that clearance. I would still take them through this monitored return to play program to make sure that you actually can see, as an athletic trainer, say that they're not having symptoms as they progress from light to a vigorous exercise. This is a great form that pretty much does all that for you, right? So if an athlete comes and they've got a remote COVID, I would give them this form because it has all the check boxes and say, you know, if your PCP cleared you, then give them this form and make sure they fill this out. And here's the details that are in there, and hopefully they're going to have a bunch of no's, and they will be good to go as far as starting a return to play. Again, I would still do a return to play progression for all these guys to make them prove to you that as they exercise, they don't have any problems that you might think are related to cardiac or COVID. So, finally, what about shutdown? So, you know, certainly, you know, as we move forward, this is a possibility. We're going to have setbacks no matter what, but understanding that these scenarios may result in us having to be in a shutdown situation. So, and hopefully we've prepared ourselves not to get into these situations where we have to do that. And I want to just finish by saying this is ultimately a risk balance situation, right? There's no perfect answer here. We're trying to maintain COVID safety and precautions, but at the same time recognizing that our young athletes and our kids right now have twice as high of rates of behavioral health problems than they did pre-COVID. And some of that may not be related to exercise, but we certainly know for some of these kids that's a huge factor, that they can't be out there. Their physical health. We know that elevated BMI and obesity is the #1 risk factor if you're looking at the younger age group. And if that's the case, we need to keep these kids in shape and exercising one way or the other. So ultimately, you know, we have to understand as a community, are we in a shelter-in-place philosophy or are we in a coexistence philosophy, and be able to proceed with the best precautions and the best risk balance from there. So these are my references. They'll all be available to you. Thank you very much. I don't think we have any questions regarding this, and I don't think we have time for questions. So what I'm going to do is basically we are going to get ready for our expert panel, and so there will be plenty of opportunity for questions there. Again, I'll go back to my original case, and we'll address that with the expert panel. They should be on in about a minute here. We're going to take maybe closer to 5 minutes to get everyone. They're going to zoom in, so just stay tuned with us, and we will be right back to get going with our multidisciplinary expert panel. Thank you so much.